In the Leeds Way tradition, my name is David Berridge. I'm the Deputy Chief Medical Officer here, Medical Director for Operations and a Consultant Vascular Surgeon by training. What's my interest in world thrombosis? For my thesis many decades ago, it was on thrombolysis for peripheral arterial thrombosis. And I sat on the National NICE Committee for the prevention of VTE. And the NICE guidelines in June 2012, I was on the expert working group for that for NICE. So I have a fairly major interest in that, and all the work that Louise is doing in conjunction with Kathryn and Lachelle and the team is obviously still very dear to my own heart. You may or may not know that across the Trust we are the second largest major trauma centre in the country with the second best outcomes. We are the second biggest trust in the country with an income of 1.2 billion. The busiest TAVI centre in the country for percutaneous thoracic aortic valves. The biggest robotic prostatectomy centre in the country. The UK hand-arm transplant centre, one of the biggest oncology centres in the country. What does this matter to world thrombosis? Well, all of that I've just mentioned is literally national, if not international class work that you as nurses and consultants, everyone put together and deliver for not only the people of Leeds, but for Yorkshire. But what is the point of doing that if we don't look after our patients in terms of VTE and have a patient who has a really successful surgical procedure, really successful chemoradiotherapy regime, to only then have the significant morbidity of a deep vein thrombosis, or indeed worse, have a fatal PE. It's really ridiculous that we let that happen in this day and age. So what I'm proud to say is that right from the very start of VTE prevention, LTHT has surpassed the initially 90% and then 95% VTE screening and prophylaxis targets. We've got a little blip at the moment, and that little blip is largely because we're bringing in electronic patient records, and every institution in the country, when they bring in EPRs, always have a little blip. And Louise and the team are doing a number of manoeuvres, including putting warnings on the EPR to make sure we don't forget. So that's just a really preamble to what is a really exciting program today. I think this is really important. So I'd like to start off first with Helen McCarthy, who's going to give our first talk. It's incidence of bleeding on low molecular weight heparin prophylaxis. For those of you who don't know Helen, she's a fifth-year medical student here. We'll be interested to hear what you've found out from the front line, Helen. Thank you.
Hi everyone, thanks for coming to listen to my talk today. So, as was already mentioned, I'm Helen McCarthy. I'm one of the medical students at Leeds, and along with one of my colleagues, Amelia Lim, and also Louise O'Prey and Kathryn Sterling, we've done our project for university, and our title was Volume of Prophylactic Low Molecular Weight Heparin Associated Bleeding at Leeds Teaching Hospitals Trust. So I'm going to do a bit of an introduction to VTE, what it is, what the problems are with VTE, and a bit about why we did this investigation. I'm also going to discuss the aims of our project, the method that we used, and then look at our results, how we analysed it, and a bit of an interpretation of that, and then some conclusions we drew from that, and also some recommendations we have from the future from what we've found. And if anyone has any questions at the end, there'll be time for that. So VTE stands for venous thromboembolism, and this includes both deep vein thromboses and pulmonary emboli. Pulmonary emboli being when the thrombus dislodges and lodges in the lungs, and that's probably one of the worst case scenarios. Across the NHS, 10% of hospital deaths are due to VTE complications, and also it costs the NHS £250 million every year, so it's a massive thing. And in 2010, there was the introduction of the National VTE Prevention Programme, which meant that everyone coming into hospital needed to be risk assessed for risk of VTE within a day of admission, so 24 hours. So the way VTE is treated, it's both mechanical with stockings and also pharmacological. And pharmacological is using anticoagulants, and in Leeds, the most common one is tinzaparin, which is a low molecular weight heparin. So no research that we've found has looked into the actual bleeding rates of it, because I know some consultants are a bit hesitant to prescribe it because they're worried it might cause a bleed. So we've looked into that. specifically for low molecular heparin in this trust. So we wanted to quantify the bleeding rates of low molecular heparin, look for any other factors that might be influencing bleeding, such as other medications like aspirin and stuff like that. And also, we thought that this might influence the clinical management of VT in the future just by providing evidence for or against the safe use of low molecular heparins. So we did a retrospective study, which means that we looked back over paper notes and online records to look at to collect our data, so it was already formed. And our inclusion criteria was anyone under the age of 18, and those who were query a cerebral bleed on CT heads and also GI bleeds on endoscopy. And these were people who'd come in for a scan or an endoscopy between July and September 2016. And we excluded anyone under the age of 18 just because there's not that much research on using low molecular heparins in paediatrics. So we collected our data over 5 weeks, and we managed to get a sample size of 124. And we didn't need ethical approval for this. We went through all the guidelines and everything for that. So these are the results that we found for CT heads. So we looked at cerebral bleed rates on the CT head. So we had people who bled and people who didn't. And then we looked through the notes and drugs records and stuff to see if they were on low molecular weight heparin or if they weren't. So for cerebral bleeds, we had a sample size of 40 patients. Of those 40 patients, 21 bled. And of those that bled, nobody was on low molecular weight heparin, whereas those that didn't bleed, 18 out of 19 were on low molecular weight heparin. So when we did all our statistical analysis, we did chi-squared tests and calculated odds ratios. This came out at 0, and anything under 1 shows that it's less likely that our exposure, which was low molecular weight heparin, influenced the outcome, which is bleeding. So being 0, that's a pretty good result. Because we had no one that bled on low molecular weight heparin, we then looked at people on other medications. So this table, this graph shows all the medications that we looked at. So warfarin, aspirin, NOACs, SSRIs, and antiplatelets. And aspirin was the most commonly used drug, and a lot of people were also on a combination of more than one of these drugs. Same sample size of 40 patients, 21 bled. And of those that bled, 15 were on other medications and 6 weren't. So this looks as though there's maybe a 2-fold increased risk of bleeding with other medications. But then when we looked at no bleeds as well, it was the same ratio, and we got an odds ratio of 1. So anything odds ratio equals 1 means that there is no association between bleeding. So moving on to GI bleeds, we looked at everyone who had a bleed on endoscopy, and unfortunately we didn't have any no bleed data, so we couldn't do any statistical analysis with this. So instead we just looked at the trends that we found. So we had a sample size of 84, and of those 12% were on low molecular weight heparin. And we did the same thing looking at the other medications as well. 40% of those that bled were on other medications. So looking at the bottom part of the table, we were just looking at trends here, but if you look at the 33%, that's patients on no other medications and no low molecular weight heparin. So 33% were on other drugs but weren't on low molecular weight heparin. And then if you move up one to the 7%, adding in the low molecular weight heparin, there was only 7% that bled. So just looking at that, it looks as though low molecular weight heparin is actually protecting against bleeding. And on the other side of the table, the 55%, that's when patients weren't on any medications and no low molecular weight heparins. And when we added in patients on no medication with low molecular weight heparin, that went down to 5%. So just from our results, it looks as though it's protective against bleeding. And this is another graph which just shows the other drugs people were on, and aspirin again was the most common, and a lot were on a combination of more than one of those. So in conclusion, using the data separately because we couldn't do any statistical analysis on the GI data, low molecular weight heparin, we found that it was statistically significant that it is protective against bleeding. And other drugs, we found there was no difference there. And GI, it also, just looking from the trends, it looked as though it was protective. So this is obviously opposite to what we thought would happen. We had a lot of limitations with our study, which I'll discuss briefly. We had a lot of problems getting access to the records and all the different online access as well, because we're students and it took a while to get access, and we had very limited time to collect the data. And we also had a small sample size. Originally, we'd calculated that we needed 400 to get a statistically significant result. So that wasn't ideal, but under the circumstances, we were quite happy with that. And also the study design with regards to the data that we collected, looking back now, we would have needed GI bleeds and no bleeds, so we could have done analysis on it. For the future, we thought that although our data is probably not the most reliable because of the small sample size, it doesn't show that low molecular weight heparin contributes to bleeding. It shows the opposite. So that's a good thing, that we know that there is no evidence to state that low molecular weight heparin is causing bleeding. We would definitely recommend that this is taken forward in the future using bigger sample sizes and the recommendations that we suggest to find better data to support this. And we'd like a larger sample size, both the bleed and no bleed data, and potentially some different coding within CT, just because it was quite difficult for us to find who definitely bled and who didn't, because it was just query bleed. So we had to go back through all the CT, the interpretations of them, and see if they had actually bled. So just a bit of coding or something to help with that, and maybe if they had bled, to put bled because of low molecular weight heparin, so it's easier to search. So that's what we found would be helpful for us in the future. This is a few references. And thank you for listening. Does anyone have any questions they want to ask?
So thank you, Helen. So I've got a question to start with, if I may. In terms of your sample size, you concentrated on those positives and negatives from a CT head.
Yeah.
In terms of your true denominator of all the patients that were coming into the trust during that period, what is your denominator for that?
Sorry, I don't understand.
So how many thousand patients were in the trust having low molecular weight heparin during that period that have produced that 40-odd patients with a CT head for hemorrhage? Do we know?
No.
No.
I know we had the total amount of the total amount we had was 911 for CT head.
Right. Any other questions for Helen?
So the potential protective aspect that you found, is there any theoretical reasons that you thought that may have occurred? Because obviously, like you said, it kind of contradicted your hypothesis that it would make it worse, and it didn't.
We haven't been able to think of any reasons, or haven't found any reasons why. So we've put it down to kind of sample size, and we'd need to do it on a bigger scale to try and find something a bit more reliable.
I think really the main message from this is it's always a little bit difficult to accept, particularly an adverse finding from a small sample. But what it does seem to suggest is there's not an excess. So I think, Helen, you're right. You will need a bigger sample, but at least it's not showing that there's anything like, an excess of bleeding, which would be the worry, but we need a little bit more. But I think it's really important work, and I think you've done really well doing this, and we need to encourage more and more medical students, but equally student nurses, to take at some of this and get some live data from the front. So thank you very much. So thank you again.
My name's Kathryn Ball. I'm one of the CT3 doctors over in, I was working over in the Beckland Centre for Psychiatry.
I'm Thomas York, one of the F1s between acute internal medicine and psychiatry.
So we both have worked on Ward 4 at the Beckland Centre, which is acute male inpatients, for Dr Mahmood, who's one of the consultants. And the reason why we looked at VTE prophylaxis was because last year, very sadly, one of Dr Mahmood's patients died of a PE whilst on the ward. He was a very young, fit gentleman actually, and it was quite a shock. And fortunately, it was nothing to do with, he shouldn't have had prophylaxis, but it still made him think, hang on a minute, we're getting quite a lot of patients admitted that should receive prophylaxis that aren't. So he asked us to have a look and do an audit into number of people receiving prophylaxis, or at least assessment anyway. So as it's already been explained, DVTs and PEs cause unnecessary deaths and chronic health issues, and this can be avoidable if we put guidance in place. And we know both from our old jobs that this is done very well in the acute trusts, but working in psychiatry, it's not done at all really on the working age adult wards. It's done quite well over in the Mount, which is for elderly patients, but not very well at all for our patients. And a lot of the psychiatric patients have a lot of comorbidities, so it's still very important. So we wanted to see, we already have, it's a different trust, we're under LYPFT, Leeds and York Partnership. So we have guidance, and it's the same guidance actually as it is over in Leeds Teaching Hospitals, but no one's really using it. So we wanted to assess if practice on the ward 4 was compliant with our own guidance. As you can probably guess, it wasn't, but we'll explain how this happened. So really everyone that's admitted into hospital should be assessed within the first 24 hours. And see if they should have VT prophylaxis. And this is the same as yourselves with tinzaparin or dalteparin if we're unable. We looked at 40 patients, this should say 2016, through 2 months, so October and November last year. We had a look at 40 patients. 2 of these patients had catatonic schizophrenia, so they were bedbound essentially for at least a week or 2. Half the patients had paranoid schizophrenia, so typically they'd be up and about and mobilising, and then the remainder had quite a wide range of mental health issues. We found that in these patients that 97% didn't have any assessment at all on admission. 2.5% of the patients did. However, this was actually done by Dr. Mahmood about a week into their admission because of his previous experience with one of his patients dying from a PE. So actually none of the patients actually on admission had this done at all. And the 2 patients that showed reduced mobility were the ones with catatonic schizophrenia. This shows you a bit more of a breakdown really about, and it just essentially says that 2 of the patients out of the 40 should have had prophylaxis. 1 of them was prescribed it, the other one wasn't. Okay, so as I said, we found that it wasn't completed for the majority, and we needed to find out how we could increase this and encourage people to follow guidance. So what we did was we presented this audit to junior doctors induction and also at teaching afternoons. But obviously there's quite a high turnover of doctors in the trust, like every 4 or 6 months. So we needed to think of something a bit more robust. So we decided actually, because we just had electronic prescribing introduced, that we can make it mandatory on EPMA in the same way as an allergy status is. So we presented it to the medicines optimisation groups and the appropriate directors, and this was made mandatory on our electronic prescribing system.
So yeah, once we put the mandatory VTE assessment in place, we ran a second cycle. Now this looked at all of the patients who were admitted to Becklin Ward 4 between April and May of this year. We looked at whether the VTE assessment had been recorded and also the diagnosis. As Kathryn says, obviously the diagnosis determines that sort of risk to an extent. So catatonic would be an increased risk. Now 59% were admitted with a sort of psychotic illness, 20% with a depressive disorder, and the remainder again with a variety of conditions. Now unsurprisingly, given it was now mandatory, we had 100% completion of this, which was obviously great, but running some of these sort of afternoon teaching sessions, we were getting some feedback that people were not entirely content with kind of accessibility and usability of the protocol. So to sort of formalise that feedback, we run a survey, and that was sort of sent out to all of the doctors in LYPFT. Quite a good return rate, and reassuringly over sort of 80% describe VTE prophylaxis as either being very important or crucially important for psychiatric patients. So the education really seems to be in place that people are recognising it as something which is a risk factor for their patients. However, we got nearly 30% of people saying they were unsure or didn't know at all where to find it and how to use it. There are also some concerns over it being mandatory in that having to do it before you can do any prescribing could potentially sort of get in the way of emergency prescribing. So looking at where we go from now, we've got some feedback suggesting that we could mirror the sort of allergy section in EPMA. I don't know if you're all familiar with that in the sort of top corner of the EMED section. Obviously that's very obvious and means you can get to it really quickly and simply without any sort of confusion as to where it is. Also looking at the possibility of doing a kind of temporary override function where you could bypass it briefly and then return to do a proper VTE prophylaxis assessment once there's time to do the assessment kind of adequately. 80% saying they were sort of sure that it was critical or very important. So there's still a little bit of sort of cementing the importance of VTE assessment in these psychiatric patients. And as Kathryn says, there's a turnover of staff in the trust, so continuing to provide that at sort of teaching. And that's everything. Thank you.
So thank you very much. A really nice, clear presentation. Gentleman at the front.
I'm a patient of the teaching trust and spent many occasions on the psychiatric wards. Why only Ward 4?
So that was the ward we were working on at the time, and when we do an audit, we took a sample of the patients, and then we know that it's very similar in the other wards. So this applies. So we've not made it just mandatory for Ward 4; it's now mandatory for the whole of LYPFT. So it covers everybody. Yeah.
Well, my background is diabetes, stroke, bipolar, and I've been on the Newsom, which is a very high, intense ward.
Yeah, it covers that one as well.
And Ward 3
Yep.
here.
Yeah.
But you've only done a percentage of Ward 4.
Yeah.
So the information we've found has shown it was sort of something that was being missed across certainly Ward 4, but that's not to say it wasn't being missed on other wards. But the sort of protocol that's now in place means it shouldn't be missed anywhere on the trust because it's across all of the wards.
Would you admit then that 20% of the people who work here should be given more information about what you've spoken about today?
I think it's just a process of kind of continually educating people. I think everyone's aware that VTE is important. It's just sort of reaffirming that and keeping it fresh in people's minds between jobs and between cycles.
So I think first of all you should be complimented in first of all identifying and proving that there was a significant problem.
Yeah.
And now that you've rolled it out, I'm not a psychiatrist, but I would try and caution you against removing it from that first step. How long does it really delay emergency treatment? It shouldn't really delay it very long.
We were discussing this earlier and we couldn't think of a reason why at all.
Well, I couldn't think of one either, because if you've seen your patient, you really should be able to fill in that checklist.
Absolutely, yeah.
And the other step which we did a few years ago is it's one thing to assess your patient, it's another to make sure they've actually received what you said they should receive. So I think that's probably the next step.
Yeah.
But I think it's a really good initiative that you've started. And just to reassure our patient who commented before, getting it established across, I think you've done really well to get it established across all of your wards.
Yeah.
But it's just that continual message, continual education to get everybody to do it. And it is difficult.
Yeah.
Are there any more questions for the team? Kathryn.
Thank you. I just wondered if you'd had any problems with the then administration of low molecular weight heparin to maybe patients who weren't that keen or were unable to fully understand why they needed it at the time.
Yes, 100% yes. We've had patients that absolutely are indicated to have low molecular weight heparin and unfortunately have absolutely refused, and then it becomes a capacity assessment and whether we should give it against their wishes or not. And in some cases we've given it when we've deemed that they're not able to make that decision in their best interest. Yeah.
I know we've had concerns in the trust for maybe our patients that come in with maybe delirium and they become aggressive when the nurse is trying to administer, which obviously then puts people at risk of a needle stick injury.
Yeah.
I just wondered if you had any tips for maybe others.
Well, we've done it on a case-by-case basis, but when it's got to the point, I could think of one particular patient in mind, it got to the point where it would put them in quite a lot of danger. It was done on a daily basis, so some days they accepted, some days they didn't. Yeah,
It's
not ideal.
It is that balance.
Yeah.
If there's no other questions, then can I thank you again? I think a really nice study, very well done.
Thank you very much. Thanks.
One of the questions I often get asked is about the use of the new oral anticoagulants, which are now called DOACs. This is the term we should be using, about if they can be used for VTE prevention in patients. Maybe when you're struggling to give them injections, maybe when patients don't want injections, maybe they don't want pork injections, because as we know, low molecular weight heparin are all sort of porcine based. So what I thought I'd do for today was actually give myself a bigger job than I meant to and have a look at the evidence base that's out there around the use of these agents for different areas of VTE prevention. I am feeling a little amiss after this talk. I haven't looked at psychiatry specifically, so I'm very sorry. That'll be something for later, but I'm guessing probably there's not an awful lot on it. So talk about the data surrounding the agents that we have available to us at the moment to help us inform decisions for maybe patients who don't manage with our usual prophylaxis. So I think what are we trying to achieve with VTE prevention? We've heard about the concerns around bleeding that Helen's presented, and that it doesn't look like our low molecular weight heparin prophylactic doses definitely increase the risk of bleeding. We talk about the importance of it, and obviously what we're trying to do is reduce the risk, and we know we're never going to prevent all VTEs in a hospital population. So we'd have to give everybody full dose anticoagulation to do that, and you can imagine the amount of bleeding that we're going to get there. So we're looking at something with minimal side effects a minimal increase in the risk of bleeding, and that's got some evidence base to it as well. So, can anybody think of why we might choose an oral agent? Just get you going with your lunch. Why we might choose an oral agent over an injectable agent, if we could? What sort of benefits do you think for your patients would that bring us? Yep. So yeah, perfect. If you're needle phobic, I don't think I had that on the list, so that's good. Anyone else? What would you rather do if you thought about it? Less painful. Yes. Reduce monitoring. Yep. Super.
Are they cheaper?
They're not at the moment, no, not because for our sort of 4,500 units of tinzaparin, I think we pay about 60p, and I think it's probably a lot more expensive it's about over £1 for the oral agents at the moment, so it's not cheaper now.
Less risk of needle stick injury?
Yeah, I got that one, less risk. So the things I got were that they were oral, so you weren't having to inject yourself, or the patient wasn't having to inject themselves, or as nurses you weren't having to go and inject everybody. It was a fixed dose, so it's more of a sort of one dose fits all rather than trying to think, oh, they're a little bit little, or they're larger patients, trying to think of those bigger doses. Patients find it a lot easier to give them to themselves than a tablet. We do get a lot of people refusing to self-inject low molecular weight heparin. No risk of needle stick injury. We don't, few side effects, and then we don't need to monitor as well. And also they're not pork-based. So for those patients who don't want to have low molecular weight heparin because of religious grounds or vegan grounds, then obviously they're better. What might be the limitations though? Why might we not be using them for... Anyone think of any limitations to their use? Irreversibility, yeah, so there's no specific antidote for these yet. Licensing, yes, they're not generally licensed, and we'll talk about that, thank you. Cost, yeah, they are more expensive. Yeah, renal function is important because most of them are renally excreted to a greater or lesser extent, so might be more having to change the dose at different points. Anyone else get anything?
If you need emergency surgery, you might need a problem.
Yep, so antidote and, yeah, super. Okay, so I had, there's little evidence for benefit and they're not licensed. If you're nil by mouth, you might get missed doses because we can't administer, which is the benefit of low molecular weight heparin around the surgical patient that we'll hear. There's no specific antidote for some of them at the moment. There is an antidote to dabigatran, but there isn't for the others. There's little data on obese patients over 120 kilos, where we've got quite a lot of data on tinzaparin up to about 165 kilos, and we do get bigger people. They are renally excreted, so they might not be appropriate for all. And there are some interactions which you just don't get with low molecular weight heparin because you're giving it as a subcutaneous injection rather than an oral. I've done a little case. She appears quite a lot. She varies in her age, but she stays quite large. So this is Jane. She's 75. She's 100 kilos, quite a large lady. She's admitted for a total hip replacement. In her past, she's had a previous DVT after some surgery. What are the options for VTE prevention for her? Total hips and knee replacements are high risk for VTE. Without treatment, up to 50% of patients can develop a DVT. Anyone know what the options are for this?
Prophylactic tinzaparin?
Yep, so tinzaparin, yep, definitely.
Rivaroxaban, obviously, with renal function.
Yep. Yep, and rivaroxaban as well, yeah. So we've got a few going there. So NICE have said that if you've had a total knee replacement, you need 14 days of prophylaxis, VTE prophylaxis afterwards, and 35 days for a hip replacement. You can use any of low molecular weight heparin. You can use fondaparinux, which is a synthetic heparin product, doesn't contain any pork. You can use any of rivaroxaban, 10 milligrams once a day, dabigatran, either 220 once a day or 150 if you've got poor renal function or other reasons for a lower dose, or apixaban. I put that in brackets because it's not in the NICE sort of overall VTE prevention guidelines, but they have approved it for use. So we can use any of those. In the trust at the moment, we use rivaroxaban. We use that for all our elective hip and knee replacement patients, unless there's a good reason why not. Possibly sometimes the warfarin patients who are going back onto warfarin will have low molecular weight heparin, so that's back in range. So I thought I'd have a look at the data surrounding that. Because this is something I hadn't really studied. So there was a big article in the BMJ in 2012 looking at NOACs for VTE prevention. So it all compared it to enoxaparin, that was the low molecular weight heparin they'd used in the trials. And they were massive, massive numbers, so something like 35,000 patients, so big, big numbers. And basically what it showed was that rivaroxaban especially showed a reduction in the number of VTE events. Now, these are VTE events that are both symptomatic, but they also scan everybody's calf after in these studies to see if there's an asymptomatic distal DVT, really. So this was a mixture of symptomatic and asymptomatic VTEs. Not all distal DVTs go on to cause a problem, to cause a DVT. So rivaroxaban really reduced it compared to enoxaparin. Dabigatran and apixaban probably fairly similar in the numbers they looked at. But what they did note in the studies were actually you got quite a bit more bleeding with rivaroxaban compared to enoxaparin. Probably similar with dabigatran and maybe a bit less with apixaban there. So they're all effective. The numbers are, so one would be equivalence, as Helen talked about already, but so they're all effective in reducing the chances of VTE post hip and knee replacements, but we've potentially got a little bit more bleeding with some of them. Now, we use rivaroxaban here, and at the beginning there were some concerns from the surgeons that there was a bit more bleeding, but I haven't heard anything more recently. They seem to have got used to them a little bit. They often delay it a bit after surgery and give low molecular weight heparin first. But overall, it shows we could have used any of them for patients with total hip replacement or total knee replacement. And obviously the benefits are they get quite extended prophylaxis and they're not having to inject themselves every day. So not having to get rid of sharps. They're not having to go home with a sharp spin and they're, 4 weeks of low molecular weight heparin. So there's some really good data to suggest that those drugs are effective. Edoxaban is the other agent, but that hasn't been studied in that population. So we've got a licensed indication, NICE approved on some data, and so we are using those within the trust. Okay, just want to throw this one in. So Jones, she's a little bit accident prone. She's come in with a lower limb injury. She's got a fracture of fifth metatarsal. An ED put a non-weight bearing cast on her and send her home to be reviewed in the virtual fracture clinic. She had she's got the same history. Anyone want to discuss VTE prevention in this lady? This is a little bit more controversial, but some work that we're doing here.
Can I ask a question about the 2.5 milligram medication called?
The apixaban.
Yeah. Is it associated with methotrexate?
With methotrexate?
Uh-huh.
No, there's no problem.
Thank you.
Is there no guidance?
So there's no good national guidance here. They sort of flipped over this area when they looked at NICE just because there wasn't much out there really.
That's harsh, Kathryn. We did look at the evidence available.
And there wasn't any, was there?
We did look at the evidence available, but you are quite right that there wasn't an awful lot of evidence available. So what NICE came out with is that patients with lower limb CAS prophylaxis should be considered according to their risk factors. So in this case, you've got somebody over at the age of 60 who is morbidly obese with a weight of 100 kg with a past history of deep vein thrombosis. So you've got at least 3 separate risk factors. So from a medical legal perspective, if DVT prophylaxis hasn't been considered and hasn't been discussed with the patient, you're on a bit of a tricky wicket.
So this is a patient that would be assessed for prophylaxis within our ED. They then go through to be reviewed in the virtual fracture clinic. They've got a non-weight bearing cast as well, so there is some evidence that increases your risk. So there's none of the DOACs, the oral agents, are licensed in the UK for other orthopaedic patients or for this. We do use rivaroxaban in ED for patients that they're putting in a non-weight bearing cast. And then they're referred through to fracture clinic if they have other risk factors. So we wouldn't do it if they didn't have any risk factors for VTE. We use rivaroxaban after a lot of discussions because it's quite difficult to maybe counsel the drunk patient on how to self-administer their low molecular weight heparin at 2 o'clock in the morning. So they use some rivaroxaban based on what other trusts do as well. And actually, there has been a study since then as well. So rivaroxaban is the main one that's been looked at in other orthopaedic areas apart from hips and knees. And there was a study. So this was a retrospective cohort study of 600 patients on rivaroxaban and 717 on enoxaparin. These were in lower limb fractures. patients. They're quite similar to what we've been looking at. And this showed that there was no real difference in major bleeding, but there did seem to be a reduction in both symptomatic and these distal DVTs are the one where they scan the calf looking for something, but the patient hasn't got any symptoms there. So you can see a reduction there. So we're fairly happy with our rivaroxaban in that pathway. Well, actually, ED and if I find a helpful orthopaedic registrar, we're going to do some work looking at that. We haven't had any VTEs in our sort of patients that aren't admitted for lower limb surgery. So these patients that are just put in casts and boots and different things like that. And we haven't had any VTEs in that group. So what we're doing seems to be working. And we've got now a bit, though it's not licensed, we've got a bit of information, a bit of a survey to pack it up. So moving on, so Jane has now got a pneumonia. She's a very unfortunate lady. Same thing again. So she's been admitted to a medical ward and we need to give her some VTE prevention. It's likely to be required, isn't it? As we've said before, her age, weight, she's got pneumonia, so an infection, so she gets another point for that. She's got a past history of VTE, so she's likely to need prophylaxis. What options have we got in our medical patient? Low molecular weight heparin, yeah.
Pretty much.
So again, the DOACs aren't licensed for medical VTE prevention at the moment. But there's some interesting data come out. So there has done some studies in this area. The first studies were done in about 2011, reported in 2011, and they were looking at apixaban and rivaroxaban. And they basically showed against enoxaparin. Now, I'm always quite interested in how people design studies. So they said, if you were having enoxaparin, you could have 10 days plus or minus 4. If you're having one of the oral agents, you could have 35 days. So they were comparing 10 days of one thing with 35 of another. Anyway. We could discuss that for the rest of the time, but so that's what they did, really. And apixaban and rivaroxaban showed a reduction in VTE events, which is probably not surprising because you've given them for longer, but actually showed quite a lot more bleeding in that group, which again probably isn't surprising because they've given them for longer. So that's never been taken forward as prophylaxis. It's quite interesting, and I can't pick out why this is different. I don't know enough about betrixaban, maybe. There's a new drug that the FDA have just approved called betrixaban. Betrixaban is another TED-A inhibitor, so like apixaban and rivaroxaban. And in their trial, they showed, fairly similar, possible slight reduction in the number of VTEs, but actually it's very similar bleeding rates to enoxaparin. And again, they use 35 days or 30 days compared to 10 of enoxaparin. So it's looking interesting. And from looking at the studies, I can't really see why it should be different. They had a very similar format. I haven't gone in detail on the exclusion inclusion, but this is looking interesting. I don't know, it hasn't gone through EMA, so this is sort of, it's only gone through the FDA and they have approved it for medical prophylaxis, but there's maybe something coming forward for those patients with that. But again, say it was 35 days. Rather than we would just use it while they were an inpatient, and very rarely, unless they had something else that would mean they needed it extended, which would normally be a pelvic fracture, or maybe they were bedbound for a longer period, we wouldn't really extend it. So whether it's relevant to what we do, but it does look interesting. So we'll have another shiny boxaban, as my colleagues call it, to look out for. I'll skip over this case because Sophie's going to present a lot around surgical VTE prevention, but just have been asked quite a lot, and the urologist got quite excited about looking at the new agents for prophylaxis for VTE. I can't find anything for non-orthopaedic surgical patients around VTE prophylaxis with the DOACs. So just stick with low molecular weight heparin or fondaparinux if they can't or don't want low molecular weight heparin. There's no data as yet on these new agents for that. Now, obviously, if you've got a patient we're really struggling with who maybe needs something oral, we could think about it, but actually there's no data to back anything up. So we're really not going to know if we're giving them anything better than, if we're giving them anything that A is going to work and B is not going to cause lots of bleeding. So no data on your general surgical population for DOACs. So continue with your low molecular weight heparin. So she's had her Hartmann's, now she's got to have some chemotherapy. So for patients with cancer, there's been a lot of discussion, there's a lot of debate, there's quite a lot of work done looking at whether patients should have VTE prevention. We know they're a higher risk because they've got cancer. And there's been quite a lot of work and different studies done looking at patients that are coming in for ambulatory chemotherapy and whether they should have VTE prevention. and what options. And we do get asked a lot about DOACs in cancer patients, mainly for treatment of VTE, because patients, the gold standard treatment is 6 months of low molecular weight heparin. You can imagine your abdomen after 6 months of low molecular weight heparin. It gets very sore. So we do get a lot of people, especially if they're needle phobic to begin with, they've managed the first few weeks or even months with low molecular weight heparin. They want to switch to an oral agent. We don't know much about them in chemo. There's lots of trials coming out hopefully quite soon, so we'll learn a little bit more. I've done a really busy slide, so I'm sorry for the next one. So basically ambulatory patients, if they've got chemotherapy, they in most cases don't require VTE prophylaxis. There was a study done, a phase 2 study, looking at apixaban in 125 patients with chemo. They compared it to placebo, and they found a lot less VTE in the apixaban patients than the placebo patients. I couldn't actually find the bleeding rates in that study. But you should imagine comparing anticoagulation, especially with quite big doses of apixaban. I mean, we use 5 milligram BD or 2.5 milligrams BD. You would expect it to reduce the recurrent VTE compared to placebo, but there wasn't anything about the bleeding rates, which should be higher there. So there's more work looking at that, and there's also rivaroxaban. Sorry, it's a bit busy. There's also some studies looking at rivaroxaban there as well, in terms of whether that might be appropriate for certain patients with cancer. I think the interesting with those is there are some drug interactions with the NOACs as well, which often makes them difficult to use in the cancer population. There's always that concern, isn't there, about the platelet count dropping and what you're going to do, as we've talked about. There's no antidote with these drugs, so is that going to be safe in the, for the patients that have a big drop in the platelet counts and then an increased risk of bleeding? If they're vomiting, they're going to keep them down. Especially with rivaroxaban, you have to take rivaroxaban with food. In the bigger doses you do, the 10 milligrams are all right, but are they going to be able to keep that down as well? And obviously, low molecular weight heparin's a bit easier in that respect. So lots going on, lots coming up in the cancer world with the use of DOACs, and probably some more around prevention as well, because that's getting more. There's been a lot more studies, haven't there, looking at that and looking at trying to prevent that and which patients we need to use it on. But at the moment, there's nothing really there. So again, low molecular weight heparin would be if we needed anything. And there's some studies on aspirin in myeloma. Okay, if you notice, Jane has suddenly reduced in age rather a lot, because I didn't think a pregnant 75-year-old would sort of stand in her case. So she's now 25 and she still weighs 100 kilos. She's got hyperemesis gravidarum and she's 8 weeks pregnant. So this was just to sort of introduce the DOACs in obstetrics, really. So is VTE prophylaxis required, and what are the options? What do you think in a pregnant patient is going to be your options here? So now anybody with hyperemesis that's admitted should be on VTE prevention. We know that pregnancy is a high-risk time for VTE, should be given VTE prevention, and we know that low molecular weight heparins are safe in pregnancy, so that's what we go for. But I was quite interested in finding out, because obviously the DOACs, they say they're contraindicated in pregnancy, so it's quite interesting to see what information is out there as well. So we wouldn't use a DOAC, we would use low molecular weight heparin. So they're all contraindicated in pregnancy and lactation. I had to look at rats and rabbit models, because that's all I could find really on the information. And rivaroxaban was the only one of the DOACs that actually showed toxicity at levels that you would see in humans. The others were all much higher levels, if I can find my bit of paper. So with dabigatran, it was 4 to 10 times higher than you'd see in the humans. Edoxaban, it was 50 to 65 times higher than you'd see in humans, is when the toxicity appeared. And apixaban, actually, the animal studies didn't indicate any reproductive toxicity, but because we've got to be safe, haven't we, in pregnancy? They've all been contraindicated. But whether things will come to light later. There's obviously issues with rivaroxaban. Also, something they don't affect fertility. So we were having a discussion about a patient who'd been told that they couldn't get pregnant while they were on drug X. And then they got pregnant because they were told they couldn't get pregnant, and had associated they couldn't get pregnant with that I won't be able to, rather than you can't, please do not get pregnant. Was very upset by that. So think about the wording that we use as well. So overall in obstetric patients, though rivaroxaban definitely looks like it will equate to some problems. The others potentially seem to be much higher doses. Whether we need them in obstetrics, I imagine if you're a pregnant woman having to have low molecular weight heparin all the way through your pregnancy, you probably quite like to have something oral, but obviously we want to make sure it's safe. It's going to be a long time before we get any of the data. So there's very little data on pregnancy outcomes. I just thought this was interesting, so I just thought I'd throw it in, really. There were 63 pregnancies reported to a German pregnancy study survey on rivaroxaban. 37 were ascertained prospectively. There were 6 miscarriages, 8 elective terminations, and 23 live births. But obviously, it was quite small. There was 1 birth with some cardiac problem, but the mum had previous baby with a cardiac problem as well, so they couldn't say it was definitely the rivaroxaban. Potentially after delivery, if mum isn't breastfeeding, then maybe for those VTEs that might be an option, but there's not an awful lot of data, but there was a case report, a patient with a new PE 5 days after starting rivaroxaban for a DVT, which she'd had 23 days post-delivery. So probably just a one-off report of a failure. I couldn't really see why otherwise you would get a failure in that level, but obviously you've got a lady postpartum, you don't want to getting pregnant again on the rivaroxaban, and obviously we wouldn't use it in lactation. And our international standards on thrombosis and haemostasis say we wouldn't give DOACs to breastfeeding women because we just can't say that they're safe, and there is some evidence that they do come out in milk. For VTE prophylaxis, there's a potential risk of fetal bleeding, and that can be intracranial, so we wouldn't use them there. And also there's potential risk of placental bleeding, miscarriage and things as well. So we just don't know enough about them at the moment, so we shouldn't be given to women of childbearing potential without adequate discussion around avoiding pregnancy at that point. So in summary, and keeping to time, there isn't much on DOACs apart from VTE prevention in total hip and knee replacements. There is some evidence for rivaroxaban in lower limb fractures, and so that's what we have been using in Leeds, more because it was easy rather than anything different. There's some emerging evidence for medical prophylaxis, for anybody there, around betrixaban, though how long that's going to take to come and whether they will put a European licence through and whether we'll be part of Europe and whether we'll do our own, is yet to be seen, really. There is data suggesting rivaroxaban not safe in pregnancy, so we do need to make sure that patients are fully counselled on not getting pregnant. And just a reminder, we need to be using appropriate evidence-based prophylaxis, which in most cases is low molecular weight heparin still, but there's maybe a few ways that we can start looking at some of the new agents there. Thank you very much. Any questions?
So, Kathryn, thank you for a really comprehensive tour of where we are and where we're going with NOACs. So, questions for Kathryn?
Can I just ask you, the study, was it over 12 months and in type 2 diabetes?
Yeah, so it was just over, I think they only followed people up for about 40 days. So it was over their hospital admission, and they did include people with diabetes as well in that one. So it's people that were admitted who were at risk of having a blood clot due to their admissions, so they were not very mobile or had an infection.
And what about type 1 diabetes?
Any patient that's admitted to hospital for any reason, I'm sure we'll talk about it as a surgical patient or anything, they are at risk of VTE, which is important. I'm not sure that either type of diabetes increases your risk factors much further, but obviously they should be assessing the patient as a whole in terms of whether they're at risk of VTE and then providing appropriate prophylaxis on that case. If you're going to be in for a very short time and you're quite mobile, then you potentially don't need any prevention. But for patients that are going to be in for any...
Just one more question. Yeah. I'm not too sure if you answer this one.
Okay.
A&E department,
yeah,
which is classed as accident and emergency.
Yeah.
When it is an accident and emergency, round Leeds or wherever, you can be waiting up to 10 hours to see a doctor. That's not very good for me.
No, I appreciate that, and I think that's why A&E departments are often very busy, aren't they? Especially getting the right people to the right places is important.
I don't want to get into a discussion.
No,
I'm just saying,
the right person to discuss
A&E is the department where people have to wait, and somebody like me with type 1 diabetes and bipolar should be found somewhere else to go rather than A&E.
Yeah, well, you're quite right. It probably shouldn't be A&E where we do see patients such as yourself, sir. So you are quite right. Are there any other questions on the question of NOACs and where we're going, though, for Kathryn? Lady here.
So I just want to focus back onto the evidence you spoke about, casting in lower limb.
Yes.
So in our diabetes foot service, we do cast people, not necessarily for sort of trauma, but we do it for Charcot and recurrent foot ulcers that we want to try and heal. Mm-hmm. So it's not something that we usually try and look at, the VTE prophylaxis. And is that something that we need to be looking at? And also if you could tell us a bit more of evidence of NOACs in that particular subgroup, please.
So are they weight bearing in what you put them in?
So bed rest is probably one of our general advice for patients with recurrent ulcerations, and obviously for Charcot as well,
and
which
do you
is
get them
part
to
of
do
the
any
treatment.
exercises, as David was describing, for their, in their feet to keep them moving and reduce their risk?
No,
of
so it's not
VTE?
something.
Okay.
So they are sort of mobile in terms of with the cast, and they're
So
not
could they weight
necessarily.
bear on the cast?
Yeah, so we advise them against that, but it's just, after your thought, it just made me think that whether we need to be looking into that.
I mean, there's very, as David described, after I rudely put it about nice, there's very sparsity of evidence. It's a big debate, and when I've asked those questions at national conferences around the lower limb fracture, of which there's probably more patients, they still haven't come to a consensus, really. There's other studies, I mean, I presented the rivaroxaban one, but there are other studies showing no benefit of prophylaxis for patients in lower limbs. Most trusts could probably tell you about the fatality they've had after a youngish person who, had a fatal pulmonary embolus after some sort of lower limb fracture. I know others around the country, they still occur. So it's a really difficult one. I mean, I think there's certain groups of patients. So if you had a patient with a big, very past medical history of VTE, but has maybe had things in relation to surgery or immobility in the past, that maybe had just got a short course of anticoagulation, maybe those are the sorts of people you need to be looking at. That risk assessment process, age, weight, how long are they going to be immobile and things. So it's maybe something we could have, but I'm not sure we'd find much evidence on it, to be honest, and I don't think we'd find anything on the DOACs, but I'm unlikely to find much on the low molecular weight heparin either, really. So we could use it as we have done with the lower limbs and look at sort of, a best fit potentially.
I think you're right, and if I could just add to that, you will, as you know, you'll find that your patients with a past history of VTE, by modern definitions, if they've had multiple, they should be on lifelong prophylaxis anyway. And even if they've had one, if it's an idiopathic VTE, the nice evidence is you should be on lifelong from a true idiopathic. So pretty much both angles are covered. Gentleman at the back.
So for that patient, obviously diabetes is not my background, but you're enforcing bed rest, making the patient less mobile, and they've got an inflammatory process going on. That's same as someone coming for a hospital with pneumonia. So the mobility factors would suggest that they do need a low molecular weight heparin. And the fact they can't weight bear, they can't plantar or dorsiflex the foot to compress the calf, again puts them at huge risk. So from a trauma background, it would be something that you would definitely screen, but I would think most of your patients would indicate some sort of chemical prophylaxis. It might.
I think it's something we could follow up on together. Yeah. Super.
Okay, and I think you've just summarised it. What we want from all our staff is to think about why aren't we using prophylaxis rather than should we think about it. No, think about it every time, and you really got to look for a reason why you shouldn't. Yeah, so the default is you should.
My name's Sophie Blow. I'm one of the firm of pharmacists who work in surgery. I have a specialist interest in our surgical admissions unit, but also perioperative medicines management. And my colleague Sophie Ridsdale's here with us today. The reason we're both here is because we work in the perioperative bridging clinics which occur in our pre-assessment services. We are actually one of, if not the first trust in the country to set up a perioperative bridging service, which we did 5.5 years ago. So lots of trusts in the UK don't even have them yet. So we're very lucky to be in a position that we can do this. So what we've been asked to talk to you about today is thromboprophylaxis in the elective surgical patients. So we're going to take you on the patient pathway from a surgeon deciding to operate or from a GP referral to what happens to that patient. So who they're going to meet, what the options are for thromboprophylaxis, who's going to be at risk, and how we're going to identify them. We will try as much as possible to relate them to the different stages where you might interact with these patients, where you might see them, to try and help everyone in this room kind of maybe take something away that you didn't know before. So many of you probably know patients come into this hospital via so many different routes, but someone who's coming in for an elective procedure, quite often the GP has referred them to see somebody. That might be because they've got symptoms in the community and they've referred them either to a surgeon directly, or they have referred them to perhaps a specialist who then refers them onto our surgical teams. So that's how they get known to us. They come usually from primary care referrals. What happens to these patients is someone decides they need surgery. So the surgeon in outpatient clinic says, yep, I'm going to go ahead, I'm going to remove your gallbladder, I want you to go to pre-assessment. They walk down the corridor, whether in Lincoln Wing at St James's Hospital or Brotherton Wing at the LGI, and they get greeted by pre-assessment nurses. And I don't know how many of you will know what pre-assessment is here in this trust, so I thought I'd give you a bit of a run through. So here it's a nurse-led service. It's intended to discuss with the patient what their procedure is. They talk to the patient about their risks, and that's the risk for the patient to come into hospital. How can they come in? It's the risk to know if they're fit for an anaesthetic, so what else is wrong with that patient apart from their need for surgery. But it's also a risk assessment for when they go home. Is there going to be anybody at home? Are you on your own? Do you have a neighbour? Do you have a friend? All sorts of questions are answered at pre-assessment that aren't just about that patient's medical condition. As part of this, the pre-assessment nurses are trained to do a detailed medication history. So that medication history is about what medicines they're on now, if anything has recently stopped. And then at this point, these patients are generally referred in the ether to one of the pharmacist teams. And that's if patients who are on warfarin, patients who might be on clopidogrel who they want advice for, anybody who's on a DOAC, they usually ring us for advice at the moment, patients who might be on tinzaparin or enoxaparin. So any of those drugs you've heard mentioned today, we might get phone calls from the pre-assessment team for some advice. What we're going to take you through today is what we have to do about that. So for many of you working on wards, if you work in an elective environment, this is one of the booklets that might well save you a lot of time if you can find it on admission. So this is called the elective procedure booking form. This is what the surgeon writes on to tell them what procedure they're having. So just in this bit up here, it tells the pre-assessment nurses what they're coming in for, but it also asks the referring surgeon if their patient's on any at-risk medicines, including any antithrombotics. So we're asking the surgeons from that very first point to try and identify those at-risk patients that might need additional intervention. We're also asking to think about if a patient's on any medicines that need to be stopped, and we're telling them which guidelines in the trust we're using to make those decisions. So we're trying to put the information to every healthcare professional out there. As you've already heard mentioned today, there's quite a lot of different antithrombotics out there. So antithrombotic is kind of the overarching definition of any anticoagulant, DOAC, and any antiplatelet. So I think we've already heard about rivaroxaban, warfarin, apixaban, aspirin, clopidogrel. We're going to touch on those today, and tinzaparin. These are used for a plethora of indications. Lots of patients you come across maybe have already got clots, had clots, but we also get lots of patients who've had strokes, who've got AF, who've got vascular disorders, who've got peripheral vascular disease, patients with heart valves. So there's no straight answer for saying, my patient's on warfarin, they've got a heart valve, what do we do? Because there's usually so many other things going on. So we're going to take you through how we risk assess these patients and how we decide if they need thromboprophylaxis or they need an alternative agent before they come in. So fundamentally what we're saying is, do we need to bridge these patients? What's going to happen to this patient if I stop their antithrombotic? Is my patient at risk of having a clot whilst off their antithrombotic, or are they absolutely fine? Okay? And this generally comes down to what is their bleeding risk versus what's their clotting risk. So there's various things that affect somebody's clotting risk, as we've already mentioned today. If they've had a stroke, what type of stroke was it? When was it? Were they on any medications when they had that stroke? If they've got a heart valve, what type of heart valve they got? If they've had a recent stent inserted in the cardiology path labs, what type of stent is it? They're all the different things that will affect a patient's clotting risk that will determine what we need to do in pre-elective patients. So fundamentally, for any of our pharmacists working there, it is a balancing risk. Are we deciding they're at risk of a clot or are they at risk of a post-op bleed? What are we going to deal with? And it is literally, sometimes it feels like this for some of our staff, because we're trying to make sure that we don't put a patient at any additional risks, but we have to stop certain medications. So how are we going to balance that? There are certain procedures that for somebody who is on warfarin, per se, we have to have an INR of less than 2. There are some procedures that we have to have an INR of less than 1.5. And all that's determined by is the bleeding risk of that procedure. So there are some procedures for patients who are on warfarin particularly, who we can tell the patient to stop their warfarin for 24 hours, 48 hours, let the INR drop so it's less than 2, but it doesn't need to be as low as less than 1.5. So you're letting them be, they're going to be sub-therapeutic, but for the shortest period of time possible. So you might decide that those patients don't require intervention. These are generally your patients who are maybe coming in for joint injections. I've put on endoscopic procedures because that's if you're not going to biopsy, but it's worth that in this trust we do thousands upon thousands of endoscopic procedures every year. Colonoscopies, endoscopies, cystoscopies, everything going. Lots of them don't have biopsies. So it's something that pre-assessment nurses are trying to clarify. Is this patient coming in? Are they going to have a biopsy? What do we need to do? If they're for a non-biopsy, they come under a low bleeding risk procedure. So they just need an INR of less than 2. Eye surgery, sometimes depends on the surgeons, but generally it's INR less than 2. And the same for the dental practice as well. Up until a few years ago, we used to bridge, which is the term when we give somebody an alternative agent when we take them off their antithrombotic orally. We used to bridge a larger number of patients than we do now. And that was down to the fact that we knew patients were at risk of a clot, but we couldn't quantify the gap between how risky it is for you to have a clot as it is to you to bleed. Now, this trial, which is aptly named the bridge trial, found that we were overcoagulating or over-bridging a large number of patients. So previously, anyone who had AF with a CHADS-2 score of less than 3 or more, and CHADS-2 is a way of risk assessing some patients on AF. So you're looking at someone who's got hypertension, age over 75, cardiovascular disorders, diabetes and stroke. Everything gets you a point apart from stroke, which gets you 2. That's where you get your CHADS-2 from. So you can imagine the older population who've got AF, we end up with quite a lot of patients with a CHADS-2 score of 3. So we found ourselves giving patients on warfarin what would take them through the bridging process. There were quite a lot of numbers. But we were then concerned, did these patients really need it? Were we putting them at risk of were they at higher risk of a bleed post-op? So the bridge trial looked at a large number of patients who were going through these processes. If you bridged them, what happened, and compared to if you didn't bridge them. So what was their risk of clotting? And it actually found that we were over-bridging patients. Not us personally at Leeds, generically, nationally, people were being over-bridged. And they raised the criteria. So AF, now fundamentally you have to have had a stroke to require bridging when you come off your warfarin. So you need to have a CHADS-2 score of 5, which is quite dramatic to patients who we previously bridged with a CHADS-2 score of 3. That's taken quite a lot of teaching or education here in the Trust, because you can imagine for the surgeons who are terrified that their patient is going to have a post-op stroke or post-op clot because they've taken them off their antithrombotic, we're now saying to them, it's all right, we don't need to bridge your patient. They've only got a CHADS-2 score of 4. They've not had a stroke. We're not worried. They are. So this trial has been really helpful to help us understand what happens in various groups of patients and how we've now changed our trust guidelines in line with national guidance, so we're not bridging or we're bridging a fewer number of patients. So how do we do this? So if we imagine a patient on warfarin, just for now, let's just think about one drug. So we'll talk about warfarin patients. We need to understand, first of all, why is that patient on warfarin? So this is where your pre-assessment handbook is very, very helpful. The nurses have quite often identified all these issues for us. It's 32 pages long, and it asks questions about patients' cardiovascular history, urology function, respiratory function, every body part going, it gets asked about. So by the time a pharmacist gets asked what to do, we already know if a patient's got a prostatic heart valve, or we know if they've got AF, or we know if they've had a previous clot. So we can use this information to risk stratify who needs to be bridged and who doesn't. So now, if a patient has got a heart valve, but it's bileaflet aortic, they don't have any other risk factors, we no longer bridge those patients. Now, Sophie will probably agree with me, we have quite a lot of trouble quantifying what type of heart valve patients have had when they were inserted 10 years ago. So we do spend a lot of time searching for cardiac notes, but we do, in the majority of cases, find out what's been implanted in patients. AF, as you can see, it goes up to a CHADS-2 score greater than 5, so only that group of patients will now get bridged. Anyone who's had a clot, if they've had a clot which was 20 years ago and nothing's ever happened since, they don't get bridging. They no longer are bridged in our services. If they've had a clot within 3 months or within 6 months but they've got an active cancer, because cancer is an additional clot factor risk, or they've had a clot whilst on an antithrombotic, then we would bridge them. So what we've tried to do is just try to make it as clear as possible for anybody, any healthcare professional, to look at the guidance and say, yes, my patient does need bridging, or no, my patient doesn't. As a rule of thumb, if someone says to you on warfarin, you meet them in the emergency department, you meet them on your ward, they have a target INR greater than 2.5, that's an indicator that you need to start thinking about what you're going to do if you take them off their warfarin. Because the low risk target INR range is 2 to 3. Anyone who's going further than that, anyone who's got a target INR of 3, 3.5, alarm bells ring, saying we need to be considering what we're doing if we're stopping their anticoagulation. For patients to get to this point, they've been through a pre-assessment, they've seen the surgeon, they're referred to the pharmacist. They come and join us 7 to 10 days before their surgery. When we've decided what we're going to do, they get an individual patient plan. This also goes onto PPM, so any healthcare professional can see it. A copy goes onto medical notes. They are taught to self-inject their tinzaparin, so it's kind of a one-stop shop. They come in, they have a chat to us, we teach them to self-inject, we give them their tinzaparin, we send them away with a pre-packed medicine so they don't have to go anywhere near the pharmacy department, they just go into pre-assessment and out the same door. They also go home with, I call them little green bags, which sounds a bit odd, but they're literally a green bag which contains a sharp spin, information on how to inject, and their patient plan we put them inside. So they have everything they need at that appointment. They then go home, they spend the next 7 to 9 days at home, hopefully not worrying too much about the surgery, but not in hospital. Prior to this service, patients were admitted 3 days pre-op. They spent those 3 days on our wards, they had intravenous heparin infusions, and they had to wait for their INR to come down. So in this trust, we're currently bridging approximately 30 patients a month, which is nearly 400 patients a year, which is just shy of 12,000 bed days saved each year, just because we're seeing them electively. That's all we're doing. We're just teaching them how to do it, we'll make an assessment and send them home, and they get to stay at home. There's also the added advantage that post-operatively, they've spoken to somebody about, we've already warned them what's going to happen. They know how to inject, they know what's coming. So we know we shorten the length of stay post-operatively, but we don't know by how much. But we do know we're saving every single patient 3 days pre-op of their bed stay. This is the sort of documentation that you might see in patients' medical notes. This is the sort of documentation that goes onto PPM. We start, day of surgery is always day 0, and we work backwards with patients who require bridging. So you count down to give the patient as long as possible, which is 6 days off warfarin in this instance, to allow the warfarin to be out of the system. We make sure that INR is falling, and we put them back on their tinzaparin, or enoxaparin for renally impaired patients. In 5.5 years, we've had one patient who needed fondaparinux, who didn't want the agents because they were pork, but that's one patient in quite a length of time. It can be done. We also use a system for patients who are on clopidogrel. So if there's somebody who's on clopidogrel who's having recurrent strokes, had a recent stent fitted, we will bridge those patients, but we might use prophylactic tinzaparin. Now, clopidogrel takes at least 10 days to be, I want to use the term out of your system, but it's not pharmacologically correct for clopidogrel. Your body has to regenerate antiplatelets. So clopidogrel, reducing them, it's an antiplatelet agent. So it stops your blood being so sticky. So when you stop it, your body's got to regenerate, it's got to make more antiplatelets. And that process is a minimum of 7 days, it's usually 10 days. So that's the length of time they're going to have to be off that agent in order for us to operate and not to be at a bleeding risk. For lots of patients, it's not a problem. For those patients that have had a stroke, so recently we've had a patient who had a stroke 6 weeks ago and they needed to bring them in for a surgery because they were high cancer risk. So we bridged them because we knew they were at high risk of a secondary stroke. But this is sort of documentation, if you're ever looking for it, these are the kind of documentation you might see. Now obviously there are other agents that Kathryn just spoke to you about, the DOACs. I appreciate this is just here for the guide. This is all information, this is all available on our trust guide, so you don't have to memorise it and take it away. There'll be no test at the end or anything like that. The different DOACs take a different number of hours to be cleared from your system. So therefore, depending which DOAC the patient's on, depending on what the patient's renal function is, depends how long they need to be off it. Now, there is actually no bridging requirement for patients on DOACs. Okay? So someone who's on rivaroxaban can stop their medication 2 days before. It's out of their system in time for surgery. They have the surgery and we start 48 hours after. There's very few patients that, I'm trying to think if we've bridged possibly 1 or 2 who've had a very recent stroke or have huge cancers or recent clots. But 9 times out of 10, nobody on a DOAC requires bridging therapy. But this just exists for anyone who's maybe on an acute setting. You have a patient on a ward who's going for theatre. They've been sat there for 2 weeks. And the surgeons say, we'll take them tomorrow. As a member of nursing staff or a junior doctor, you can say, do you know what? They're going to be at increased bleeding risk. Maybe we need to do it the day after that. So this is just there as a referral guide. It's in all the trust guidance. The next step on the patient's pathway is they come to hospital. So this has all happened pre-surgery, okay? This is the lovely Lincoln wing, which is where we've got our admissions lounge at St James's Hospital. Patients are brought in on the morning of their surgery, sometimes a bit later, but generally at 7:30. They come and they meet the surgeons, they meet the anaesthetists, they meet members of the pharmacy team, and that's when they're prepped for their theatre, and they're going to go at some point that day. And it's at this point, if you're clerking that patient, there's some serious questions we need to ask, okay? So 1, do they need to have their VT risk assessment form completed? Yes, they do. They must have it before they go to theatre, okay? That's a trust process here at St James's. They also need to have their VT prescription done at that point in the admissions lounge. If you're nurse, doctor, anaesthetist clerking these patients, have a look for that elective admission booklet because it will answer so many of your questions. If your patient tells you they've been injecting tinzaparin or enoxaparin, You want to find their personalised treatment plan, which is on PPM. It's also in that booklet. Okay? You want to check their U's and E's. You want to make sure their renal function is all right. You want to make sure they've excreted their drugs. You want to check FBCs and clotting and INR, all the morning of surgery. If you've got a patient telling you they've had injections at home, the key thing to say to them is, when was your last injection? And just get that documented on the clerking. Because if that patient tells you they injected that morning before they set off, we're going to have to potentially, 9 times out of 10, change their surgery, cancel it. Okay, it wouldn't be safe to take them for surgery. If you've got a patient who is taking any of the antithrombotic agents which are oral, so your warfarins, aspirin, clopidogrel, just ask them, when did you last take it? Okay? Their individual plan might tell you that they were told to take it 6 days ago, but we have had patients who've kept taking it and still had the tinzaparin. So it's a good question to ask. And of course, if you're ever concerned when you're clerking a patient on the day of surgery, just refer to your medical, surgical, pharmacy colleagues and we'll give you advice where we can. These are the same rules that apply elective and acutes. I know it sounds a bit funny to say, but if you've got an acute setting patient, you can apply the same rules to the patients. You know, these are the same questions you can ask them if you're going to take them for surgery that day. Now they're going for surgery. So I'm going to hand over to Sophie. She's going to take you through the surgical pathway. Hopefully the patient's going to get home.
Thank you, Sophie. So as Sophie said, I'm just going to talk a bit about what happens after the surgery for the elective surgical patient. So after they've had surgery, it'll usually be at the discretion of the operating surgeon or anaesthetist about whether we need to restart any bridging anticoagulation, if we're going to or when we're going to. So this will be an individual risk assessment for that individual patient based on the risk of their bleeding versus their thrombotic risk. So usually with the bridging anticoagulation, we would restart the low molecular weight heparin or unfractionated heparin, and that has a rapid anticoagulation effect. So we would want to consider that with the decision made. So sometimes we would consider whether we would use fractionated heparin. So that has the benefit of that it's quite easy and fast to reverse if we needed to. Or also a consideration to whether we'd give a prophylactic dose of low molecular weight heparin after the operation, a split dose, so basically a half dose of a therapeutic dose, or a full dose of the therapeutic low molecular weight heparin. So following on from that, once if the bridging anticoagulation has been restarted, we would consider for patients who were preoperatively on warfarin about when we would restart the warfarin. So this wouldn't be restarted until we were happy that there was adequate hemostasis following the operation, but also once the oral intake was re-established. So if we restart, so this couple of implications in that, so if they're nil by mouth or they're not having any oral intake, they won't actually be able to take the warfarin. But also, because of the way the warfarin works in the body and how it's impacted by what you eat and drink, etc., and interactions, if you've got a patient who's not eating and drinking as much as normal, restarting their warfarin may cause them to react differently to how they would preoperatively. So we'd wait until their oral intake's established and they have adequate hemostasis, but also when we're quite convinced that they're unlikely to need any further invasive procedures. But before we would restart the warfarin, we would recheck the clotting to check it's back to baseline or it's not raised for any other reasons. So also we need to, like I said, warfarin can be impacted by oral intake and food or alcohol, etc. But also it commonly interacts with a lot of medication. So when we're looking to restart the warfarin after the operation, we need to review whether there's been any significant medication changes. So one of the most common things that interacts with warfarin is antibiotics. So if we've got a surgical site infection or still some residual infection following an operation, we would need to take that into account when we're looking to restart the warfarin. So we basically have a choice of whether we restart with their on-admission dose of warfarin or whether we would use 2 loading doses to kind of get them back into their therapeutic range following the operation. So this is taken from our trust guidelines, and so if we've looked at the patient and we're happy that they've got established oral intake, they've not had any significant medication changes that's going to impact the warfarin, we would consider giving 2 doses of a higher dose of warfarin to get them back up and into therapeutic range faster than if we just restarted the on-admission dose. So for some patients, if we just start their on-admission dose, it can take 5 to 7 or even longer to get back up into their therapeutic range with their INR. So giving these 2 loading doses can achieve the therapeutic INR quicker than just on admission dose. But depending on what their on admission dose is what we'd choose. So as you can see on this slide, if it's less than 8 milligrams, we'd give 2 days of 1.5 of their usual dose, and then if it's greater than 8, it's 1.3 times. So if they've been bridged with low molecular weight heparin or unfractionated heparin, we would continue that bridging until the INR is above the lower end of the target range. And like I said earlier, so having 2 loading doses would be a faster achievement of the therapeutic INRs, so that would often mean a shorter duration of parenteral anticoagulant. So I've talked a bit about restarting warfarin after surgery. So in terms of other antithrombotics, again, we want to make sure that the hemostasis is adequate after the surgery, oral intake's established, and they're again unlikely to need any further invasive procedures. So for other antithrombotics, so the DOACs or aspirin, clopidogrel, we would resume their usual on-admission dose. We wouldn't give any loading or boost doses for that. Once we've resumed their on-admission antithrombotics, it's really important that we review the low molecular weight heparin if they've been prescribed it. So often for antiplatelets, we would continue the prophylactic dose alongside them for at least while they're in hospital, possibly longer if they need extended VTE prophylaxis. Whereas with anticoagulants like the DOACs, when they're reinstated after surgery, we would stop the low molecular weight heparin. I've just included this slide just to illustrate some other considerations we need to think about when we're restarting or stopping the anticoagulants around the time of surgery. So this table just illustrates about removal of epidural catheters. So for the DOACs or the heparin, this shows the time that after the dose we need to wait until we remove the catheters, or the time after the next dose that we could remove them. So as you can see, it can differ, can have some implications wider. So for patients who are on warfarin and have restarted the warfarin after surgery alongside the low molecular weight heparin, when it comes to discharge, we need to think about how we're going to manage that and how they're going to be safely followed up. So for any patient who's on warfarin and bridging low molecular weight heparin, they can go home on both, but we need to just make sure that they've got a safe follow-up plan, which would be a consultation anticoagulation clinic appointment. And depending on the patient's individual circumstances, this would be usually quite soon after discharge, but within 2 to 5 days as clinically appropriate for that patient. We need to make sure that they've got an adequate supply of the low molecular weight heparin on discharge, and also that they're able to administer it. So as Sophie touched on, if they've come in with pre-operative bridging, we've taught them how to administer it, so they should be able to do that, but we would check that that's still the case following their surgery. And also, if they can't do it, is there anyone else that can help them, like friends or relatives? And Kathryn has previously today spoke extensively about the extended VTE prophylaxis, but I just wanted to touch on it briefly, so that there's multiple surgeries are associated with a high risk of VTE, and the extended course of VTE prophylaxis can be given post-operation. And this is often speciality or procedure specific, but also you can have extended VTE prophylaxis for patients who aren't already on any antiplatelets, anticoagulants. And again, we would teach the patients how they would administer it themselves or their relatives, and this is just a link to the guideline that we have here at Leeds of how to teach patients and carers to administer that themselves. So that would move the patient hopefully safely onto a discharge home. And so in summary, we've considered the elective surgical patients pathway from the decision to operate to home, and shown that a consideration towards thromboprophylaxis is required at every step of that elective surgical patient's pathway, and appropriate management can reduce morbidity and mortality to make sure that we provide patient-centred, high quality and safe care in line with the Leeds ways. So thank you very much for coming and your attention, and me and other Sophie are happy to answer any questions that you've got.
Sophie and Sophie are really detailed journey through surgical prophylaxis. So questions for the team.
That's what you already said. really, because seeing patients at the other side of the bridging is that we do sometimes forget within the trust to tell them to restart their warfarin, so they think they're just taking their tinzaparin, or we get patients that have just got the warfarin and weren't really sure what to do with the injections. So just to think about in your patients, if they are going home, making sure they're educated on that. I know we do that very well on a lot of the wards. I think sometimes Mother Day cases sometimes not quite sure what to do for that. So just for add to what these ladies have said very well already.
Well, if there aren't any other questions, can I thank you again? I think it's a really helpful disposition. Thank you.
Thank you.
Just got some case studies. So this was a 71-year-old lady who came into the trust. She was admitted on the 28th of June this year with a C1 bony lesion and a cord compression. So she was for surgical decompression surgery. And unfortunately, her surgery was delayed. So she came in on the 28th of June and she didn't have a surgery until the 6th of July. So on admission, she was risk assessed, and the doctor that did the risk assessment identified that she had a high BMI. She was relatively immobile. She was also on AF for apixaban. But they didn't identify that she was over 60. So, my questions to you are, was thromboprophylaxis appropriate for this patient? Do you think it was? Do you think she should have had some thromboprophylaxis? Yep. Does everyone agree with that? Anyone think she should have stopped, or was she still on? The apixaban was stopped. Yeah? So everyone agrees she should have had some thromboprophylaxis, yeah? And then, do you think she should have the mechanical prophylaxis or low molecular weight heparin? She was for neurosurgery, but she didn't get a surgery until quite a long time after admission. So what would you have done with her?
Was she due a surgery the day after?
She was due it and it was delayed twice, but... Both. You're going with both. Is anyone else going for both? You're going for both? Yeah, both at the back. Okay. So why do you think she should have had both?
She's got significant risk factors.
Yeah.
Her surgery wasn't planned until the following morning, so she's got a prophylactic tins at usual 6 p.m. drug round. She was presumably going to be immobile, so she should have had a compression, and there was no mention of lower limb kind of an ulcer or anything else in the history. Okay.
So what actually happened to this lady was that she came into hospital, her apixaban was stopped because they thought she was for surgery. She wasn't prescribed any low molecular weight heparin until 2 days post-surgery. She wasn't prescribed any Flotrons or any other intermittent pneumatic compression. She was then, 2 days after surgery, prescribed tinzaparin 4,500 units, but at that point, the doctor identified that she possibly weighed over 100 kilos. She was weighed on that day and she weighed 113 kilos, but the dose wasn't increased. So she should have been given 6,000 units, but no one did that until the 10th, so 2 days later. She then developed a suspected DVT, so she was started on treatment dose tins, and a DVT was confirmed on the 12th. So do you think this event was preventable?
Yeah, potentially.
Yeah, I agree. I think this was a potentially preventable VTE. So the doctor who assessed the case assessed it as preventable and said that tinzaparin should have been prescribed preoperatively, and the dose should have been 50 units per kilo, so should have been 6,000 units, and also should have had Flotrons. So we had to follow the duty of candour process for that VTE. So we had to talk to the patient about the fact that it was a preventable event and the things that we should have done to stop her from getting that VTE. So we let that patient down, essentially, unfortunately. So this case was a 78-year-old gentleman who came into hospital on the 14th of June. Following a fall, he was confused and it was queried due to sepsis. He had a lacerated nose and bleeding nostril from his fall. And then the day after he was admitted, he had another fall whilst he was in hospital. So he was risk assessed and they identified that he had significant comorbidities. We didn't identify that he was over 60. It was a prothrombotic state because of query sepsis. And we didn't identify any bleeding risks. So do you think thromboprophylaxis was appropriate for this gentleman? Yeah? Okay. And do you think we should have given him mechanical prophylaxis or low molecular weight heparin? Mechanical? Okay. Why do you think mechanical? Not low molecular falls risk. Okay. So what actually happened for this gentleman was he wasn't prescribed thromboprophylaxis because of his falls risk. So no low molecular weight heparin and no mechanical aids either. And then he wasn't re-risk assessed until 3 days after he'd been admitted. So at that point, falls was identified as a bleeding risk. Thromboprophylaxis still wasn't prescribed, but at that point, it was actually one-to-one nursed. So it was being specialled by one nurse all of the time. So I think at that point, actually, we could have perhaps added in some tinzaparin because actually his risk of falls at that point was probably quite low because he was being nursed by one nurse. What happened to this gentleman was that he was discharged home about 8 days after he was admitted. He was found collapsed at his residential home and he had a cardiac arrest when he arrived in A&E. He went to the coroner's court, he died, it went to the coroner's court and PE was diagnosed as the cause of death. Incredibly sad. Do you think that was preventable? Anyone? David?
Well, I think it's possible, but then you've got conflicting interests quite a bit the way through the management. So I think, from a medical legal point of view, you could defend most of that, but it depends on the timing at the end. So it's not as, I don't think it's quite as clear cut as the previous one.
So again, this was assessed as preventable because of the special the one-to-one nursing, because actually we were sort of there preventing him from falls. And he should have been re-risk assessed earlier in his admission. And so the doctor who completed the form did deem that we should have given some low molecular weight heparin prophylaxis for this patient once he was specialled.
That's fine, but on discharge, you would assume that his level of mobility and supervision and falls risk, often you would stop low molecular weight heparin at that point. So he had an 8-day window where he wouldn't have had it and could have still developed P anyway just to secondary factors. So
I do totally agree with that, but I think while he was an inpatient, we had a duty of care to do the right thing for that period.
I think the mechanical is interesting. There's not much, very small evidence around mechanical methods for medical patients. A lot of it's extrapolated from stroke and studies and from surgical patients where there is more good evidence for mechanical. So there really isn't much evidence for mechanical, and I think we don't tend to think about it particularly, but say that the evidence is very lacking within that area really. I think it's the re-risk assessment and the thinking about, he's coming because of falls, fair enough, and we've seen people who've had lots of falls and they're black and blue and things, but then it's the re-risk assessment is really important to keep going with that, to think about that, how that patient has changed over the time period really as well.
This gentleman was 71 years old. He came in on the 2nd of May with a cough and shortness of breath. The risk assessment was done and VTE risks were identified, but they missed that he'd had a previous clot. So I did identify concurrent use of anticoagulants, that it was on rivaroxaban for a previous VTE, but they didn't actually put the previous VTE on the risk assessment form. He didn't get his rivaroxaban, so it wasn't administered from the day after admission until the 6th of May because it was query for a chest drain insertion. Then from the 7th of May until the 12th, it wasn't administered because he was nil by mouth. The chest drain wasn't actually inserted until the 11th of May, so a week after admission, and he developed a PE on that day. So do you think he should have been prescribed thromboprophylaxis? Yeah. Yeah. And what sort? Mechanical? Tinzaparin. Okay. Why do you think tinzaparin? Yeah, absolutely. So, what dose would you have given him? I don't know, it was a root cause analysis and they said that they'd identified risk factors but they didn't tell me exactly what they were.
Treatment dose. I think treatment dose.
Treatment dose, okay. He actually wasn't prescribed any thromboprophylaxis. No one re-risk assessed him and he went on to get a VTE and it was assessed as preventable because he should have been given some low molecular weight heparin. So he had a DVT, it was assessed as preventable, And he didn't even get the chest drain until much later, and he was nil by mouth, so he should have been given some thromboprophylaxis, but we didn't do it. So again, assessed as preventable, and the duty of candor process was followed for this patient.
I think it's important to think about when if patients aren't managing to take the medication for some reason or another. So he was nil by mouth, so he couldn't have taken his rivaroxaban, as we've talked about. It needs to be given with food. So about, thinking about, as a nurse, maybe if you're doing the meds round and going, I can't give that to the patient, well, what's it for? Do we need to think about anything else, highlighting it to the team, or think about, the state of the patient? Because the discussion about low molecular weight heparin, whether you're given treatment or prophylactic dose, is probably, if you're given something, then we would, and they'd still had a clot, then, I think that would have been unfortunate, wouldn't it? But actually we gave nothing, and he was on an anticoagulant already, so we hadn't thought about replacing it.
And it massively illustrates the need for re-risk assessment, because actually if we'd have thought about it and re-risk assessed him, we might have picked up on it and might have started some low molecular weight heparin. And just my final one. So this was a 70-year-old lady who came in on the 15th of June with dizziness and unexplained loss of consciousness. And the patient had a history of a DVT a long time ago, in 1987, and was on AF. So had AF and was on warfarin. She was admitted with aqueous stroke. So the warfarin was withheld because they were awaiting an MRI. She was risk assessed and found to have reduced mobility. She was over 60, had comorbidities. They didn't identify the previous VTE, but they did identify bleeding risks, so the risk of hemorrhagic transformation of the stroke. So do you think we should have given this patient thromboprophylaxis?
Probably Flotrons.
Flotrons. Okay. Anyone else? Flotrons? So what actually happened to this patient was that a warfarin was withheld. She wasn't given Flotrons or any other intermittent pneumatic compression devices. And she was sent home on antiplatelet therapy, no warfarin. And she developed a PE 5 weeks after admission. Do you think this one was preventable? Yeah. Yes. So again, this DVT was assessed as preventable because we should have fitted intermittent pneumatic compression devices. What went wrong with this patient was they weren't actually admitted to the stroke unit. They came in under medicine, and I actually think we need to do some work around that, because I don't think we're always as consistent if we get a stroke patient in medicine at using Flotrons as we are if they go to the stroke unit. So again, we follow the duty of candor process. And that's it. Thank you.
So, thank you, Louise. Can I just ask you, at the risk of stating the obvious, were all these patient histories from within LTHT?
Yes, sorry, yes, they were.
And how many of these were within the last year?
All of them.
All of them. So I presume that's what you're going to say. So in other words, we think we're pretty good, and we are pretty good at risk assessing our patients for VTE and actually giving them the treatment. But there's enough cases there that are still preventable that have slipped through that net. So the more we can get up to that elusive 98, 99, dare I say 100%, the better. Because if it was you or I or one of our relatives coming in, wouldn't we want them to have prophylaxis? We certainly would. Certainly whenever I've gone into hospital for a relative, one of the first things I look at, with their permission, is are they on a low molecular weight heparin, and if they're not on a low molecular weight, where's the Flotrons, where's the graduated compression stockings, and if ever I'm in, that's the first thing I would want.
I'm Etienne Chanter. I'm a consultant obstetrician, and I run the obstetric hematology service in the LGI in conjunction with my hematology consultant colleagues. So we do a weekly hemostasis and thrombosis clinic for our pregnant women, because there's quite a lot of them who are at a high risk of getting a VTE, and we're never short of patients, so they always keep coming. So that sounds quite a scary title, major killer, but it is. It is the commonest cause of death in the UK in pregnancy. So the commonest cause of death in a pregnant woman in the UK and in Ireland is a VTE. So, and this is from very solid work, which is done every 3 years. So in obstetrics, every 3 years a report comes out which brings together all the maternal mortalities. Yeah? And they go through all the cases and come out with a lot of statistics. And venous thromboembolism has consistently been the top killer. So it's 20 deaths in 3 years, which doesn't sound like a lot, but it's a lot for those 20 women and families, obviously. You're not meant to die when you're pregnant, because pregnancy is a physiological process, isn't it? So it's a catastrophe when that happens. So VTE is by far the commonest, followed by amniotic fluid embolism and hemorrhage in third place. It's different from other European countries. In France, for example, the commonest cause of death is hemorrhage, while we have VTE as our commonest risk, may be related to our higher obese population compared to other European countries, but that's just speculation. So, why does it happen? In pregnancy, you are 5 times more likely to get a blood clot compared to when you're not pregnant. So that's already you're starting from a weak spot already when you're pregnant, because you're 5 times more likely to clot, and that's because blood is much clottier when you're pregnant. So all the clotting factors which are circulating in our bloodstream increase during pregnancy, especially von Willebrand factors and factors 7, 8, 9, and 10. What also happens, your fibrinogen level, which helps your blood clot, also goes up. And your fibrinolytic activity, so the capacity of your blood to dissolve small clots, is reduced. And all these changes occur from the very beginning, from conception, pretty much. So it's not about the gravid uterus causing pressure. That is also important, but the clotty changes occur from conception. So that's one reason. Another reason why you're more likely to clot when you're pregnant is because of a reduction in blood flow. So there is dilatation of your lower limb vessels in pregnancy, and the blood flow through the major veins decreases. That is because of, as I said, the dilatation of the vessels and the pressure on the veins of your legs from the uterus. It is more marked on the left. So it's you're much more likely to get a blood clot on your left than on your right when you are pregnant. So who is going to tell me what is the percentage of DVTs on the left in pregnancy?
80%.
Yeah, any other offers?
70.
90. So 90% of blood clots in pregnancy occur on the left. So it's very uncommon to get a blood clot on the right. When you're not pregnant, the ratio is 60 to 40, left to right. So there's always a bit of a preponderance to the left, but it's much more marked in pregnancy. And how many blood clots in pregnancy are above the knee? You need to tell me a number, otherwise I won't carry on. Pardon? 20? Any other offers? So it's 70 actually. So 90% of blood clots occur on the left and 70% occur above the knee. And why is that important? Why, as an obstetrician, am I worried about blood clots above the knee? So what? They are large blood clots because they occur in the large veins, yeah, and they're more likely to embolize, therefore, to cause a pulmonary embolism and therefore potentially cause death. Okay, so when I always tell my junior doctors that if you have a woman who comes in with a right popliteal DVT, I'm not going to believe you, yeah, because it's unlikely. It's much more likely to be on the left and above the knee. I do believe them, but with a pinch of salt. So why does it occur? It occurs because there's an anatomical reason for this to happen. So anatomically, your right common iliac artery presses on the left common iliac vein. That is how we are. So you're more likely to have a blood clot on the left because of pressure on the left common iliac vein. That occurs even when you're not pregnant, but when you're pregnant, that pressure is exaggerated by the gravid uterus. So we talked about 2 changes which occur in pregnancy which increase the risk of blood clot: the changes in the blood constituents, and also the reduction in blood flow. So as you can see here, that is why you're more likely to have a blood clot above the knee than below the knee, because there's a much bigger reduction in the blood flow through the common femoral vein compared to the popliteal vein. Yeah, so that reduction in blood flow predisposes you to a blood clot. The third reason why you're more likely to clot in pregnancy is because of vessel trauma. When we're doing cesarean sections, I don't know how many of you have actually watched a cesarean section, but it's quite a bloody operation, and we have to put our hands in and to deliver the baby, and we're manipulating the pelvic veins quite a lot. And that trauma, that pressure which you're causing on the pelvic veins triggers blood clots, because you're causing trauma to the vessel wall. In fact, when you compare a C-section to a normal delivery, you're 5 times more likely to have a blood clot after a C-section compared to a normal delivery. An emergency section is more likely to give you a blood clot compared to an elective cesarean section, because these women would have been in labor for a long time. Usually they would have been in bed for a longer time. And instrumental delivery is also forceps, for example, do increase your risk of blood clots more than a normal delivery because of trauma to the vessels. So there's 3 components, therefore, which increase your risk of blood clotting in pregnancy. The fact that pregnancy is a hypercoagulable state because of the increase in the clotting factors and the decrease in the fibrinolytic activity, the reduction in blood flow, especially in the upper leg veins, and vessel trauma as well. So these 3 components have a name, actually. Does anybody know what this name is? Virchow's triad. Very good. So Virchow was a German biologist, politician, and many other things, who actually coined together these 3 components, which are quite important and increase the risk of VTE in pregnancy. So, as I said already, you're 5 times more likely to get a blood clot in pregnancy compared to the non-pregnant state. We quote an incidence of 1 in 1,000. So the incidence we quote to our patients is 1 in 1,000. If you don't have any other risk factors, if you have other risk factors, like, for example, smoking, high BMI, that risk then goes up. 80% of VTEs in pregnancy are DVTs, while 25% are PEs. But in the postnatal period, you're more likely to have a PE compared to a DVT. And this is what the incidence is. So 10% of blood clots occur in the first trimester, another 10% occur in the second trimester, while about 30% occur in the third trimester. 50% occur in those 6 weeks postnatally. So you're very, very high risk in those 6 weeks postnatally. In fact, when you compare the postnatal period to the antenatal period, you're 20 times more likely to have a blood clot in the postnatal period. And you're 60 times more likely to have a blood clot in the first 10 days after delivery. So the postnatal period is a very, very high risk period. And why do you think, because you would expect the first trimester to be lower than 10%, isn't it? You'd expect it to be a gradual rise. Why do you think the first trimester is relatively high? What happens in the first trimester which increases your risk of blood clots?
Got higher surgery hormones released?
Yes, but there's a particular type of pregnant women who have even more hormones. So if you have an IVF pregnancy, you are loaded with estrogen, and estrogen is the prothrombotic hormone. So the first trimester is quite high risk because of the IVF women, which are taken into consideration. And there's something else which happens in the first trimester. If you've been watching the news, there's a particular important person who gets this complication every time she gets pregnant. Hyperemesis, yeah, so Duchess of Cambridge gets hyperemesis every time. Hyperemesis is quite prothrombotic because you're in hospital, you're dehydrated, and quite a lot of women, but the risk of getting a VTE with hyperemesis is relatively high. So that explains the relatively higher risk of VTEs in the first trimester. So my talk is on prevention, but we had to learn a bit about why do you get VTEs in pregnancy before we talked about prevention. So how do we prevent VTEs in pregnancy? We have a very strong guideline, a very solid guideline. When you compare our practice to all the other industrialized countries, we probably have the best risk assessment tool. I was quite surprised that a few months ago I was in Spain on an international obstetric hematology meeting, and I was sharing lunch with Dutch colleagues. Now, Holland has a very, very good obstetric service, and they were very surprised that we had a VTE risk assessment for pregnant women. They asked me, so is it true that you risk assess every woman who's pregnant for VTE? I said, yes. What a stupid question to ask, I said to myself. And they said, oh, that's incredible, because we don't do that. And I was very, very surprised. So we have a very, very solid risk assessment tool, but unfortunately, we don't always get it right. We do have patients falling through the net sometimes. And the guideline which we have in our trust is based on the RCOG guideline, the Royal College of Obs and Gynae guideline, which has been rewritten, which has been edited just a few years ago. So we are getting better. We are always getting better with our VTE prevention in pregnancy, but we're not always getting it right. There are some things which we are not quite good at yet. One of them is dosage. Yeah, as Kathryn knows very well, we don't always get the dose right. So the standard dose of tinzaparin for VTE prevention is 4,500, but that's only if you weigh between 50 and 90 kilos. If you weigh more than 90 kilos, it's 7,000 units. So what often happens, the registrar, the SHO, or even the midwife, they look at the booking weight. So the weight of the mum when she booked, when she was 12 weeks pregnant, which may have been between 50 and 90 kilos. But by the time she had her baby, it may have gone beyond that bracket to a bracket which requires a higher dose of tinzaparan. And we've had quite a few women having VTEs because of that. So the dosage is key. We need to start early. There are some situations, which I'll show you in a second, where VTE prophylaxis has to start from the very beginning of pregnancy. You can't wait until the woman comes to clinic 2 weeks later. It needs to be started by the GPs from the word go. We used to have lots of issues with that happening because primary care were reluctant to prescribe tinzaparan on women we haven't seen yet. But that seems to have ironed itself out now with the writing up of AMBER guidelines, which does allow GPs to prescribe low molecular weight heparin on pregnant women, and the problem seems to have resolved. We have to remember also that low risk women may become high risk for VTE as the pregnancy advances. Yeah? So they might not require thromboprophylaxis from the beginning, but later on they might need it. So that is where sometimes we get it wrong. So risk assessing a woman every time she sees a midwife or a doctor is imperative, and that's what our guideline says. So there are various risk factors which increase your risk of VTE in pregnancy even more, and the most important risk factors are a previous VTE. If a woman has had a VTE in the past, her risk of having a VTE in this pregnancy goes up from 1 in 1,000 to 1 in 10. So it's extremely high. Or if she has a thrombophilia, so a heritable blood clotting condition. And 50% of women who have a VTE in pregnancy have a thrombophilia, which therefore means 50% of women who have a VTE do not have a thrombophilia. So if you have a thrombophilia screen which is negative, don't be falsely reassured by that. She can still get a VTE. And that's because there's so many things which are happening in our blood which we do not know of yet, and we haven't got any blood tests yet to pick these up. So this is just to show you, to compare the odds ratio of the different risk factors. So if you've had a VTE in the past, your odds ratio of getting a VTE in this pregnancy is 25 times higher, as opposed to 1.3 times higher if you're more than 35 years old. So this is how our guideline looks like. So it's extremely complicated, it's complex, but when you look at it I'm sure it doesn't portray very well, but if you go onto the intranet, it's on the intranet. Yeah? If you type VTE prevention on the guideline section of the intranet, it's there. So there's the low risk factors, the intermediate risk factors, and the high risk factors for the antenatal period. And this is for the postnatal period. So if a woman has 4 of these risk factors, like she's a smoker, for example, she's more than 35 years old, it's an IVF pregnancy, and she has a BMI of more than 30, that gives her 4 risk factors, and she needs low molecular weight heparin from the beginning, from conception. If she has 3 risk factors, then she needs thromboprophylaxis from 28 weeks. Because as you remember from my graph, there's a rise from the 2nd to the 3rd trimester of VTE risk. If she has 2 risk factors or less, she does not need low molecular weight heparin prophylaxis. If she has an intermediate risk, then you consider antenatal prophylaxis. If she has a high risk, like VTE in the past, then there's no question about it. You give her thromboprophylaxis straight away from conception. And it's quite similar for the postnatal period as well. So I do encourage you to have a look at the guidelines on the intranet. So you might think the guideline is extensive. It's about 60 pages long, so it is quite extensive. Many recommendations are low-grade evidence. Unfortunately, in obstetric hematology, lots of things we do are not really supported by evidence, because you can't do lots of research on pregnant women. You can't say, we'll give you a drug and we don't give you a drug and see what happens. You can't do that in pregnancy, isn't it? So you have to base your evidence on case studies, on case series, on retrospective stuff, which is not as strong as proper double-blind studies. But that's all we've got, and we seem to be doing quite well. It's cost effective, it's quite efficacious, and it does not lead to harm. Low molecular weight heparin is safe in pregnancy. It does not cross the placenta, so baby does not get any anticoagulation, as opposed to warfarin, which does cross the placenta, and it reduces your risk of getting a VTE by 90%. So it's very, very effective, and that is supported by evidence. So as I said, the main risk factors for getting a VTE in pregnancy are if you've had a previous VTE, which increases your risk by 100 times, but between 25 and 100 times. If you have a family history of a VTE, that is also a significant risk factor, and if you have a thrombophilia. This is all important because afterwards I'll give you a few cases which we have come across, and we'll try to work out whether these women require thromboprophylaxis or not. If a woman comes to clinic with a history of a previous VTE, it's very important to take a good history. I often, not very often, but sometimes I see women who come to me with a history of previous VTE. So I ask them, so what happened 5 years ago? Oh, I had a DVT, right. So so what happened? Tell me what happened. I came into hospital with a swollen leg, right. And how long were you given the injections for? For 1 day. Okay, so you probably did not have a DVT, because that what probably happened, they thought you had a DVT, you had a scan, it was excluded, and therefore they stopped low molecular weight heparin. Oh, all right then. so wasted appointment. But fine, we'd rather do that than miss case. So you have to make sure that it was a proven VTE, and you have to ask her therefore, how long were you treated for? If she tells you 3-6 months, then it probably was a proven VTE. Where was it? If a woman has had a PE, for example, or a large iliac vein DVT, I'd be more worried than if she had a popliteal DVT. Was it estrogen related? Why is that important, you think? If somebody comes to me and tells me I had a DVT 5 years ago when I was on the pill, and now she's pregnant, why would that worry me more compared to a DVT which occurred after a long-haul flight? Absolutely, very good. Yeah, so she was probably got a DVT because of the estrogen she was consuming, and now she has the same estrogen challenge because she's pregnant. So her risk is relatively high, while if it was a long-haul flight, that was provoked by the long-haul flight. And is there a family history? You need to ask that as well, quite importantly. And if there is a family history, you have to ask, was it a female relative? Because that puts her at a higher risk. Was her family member, did she get a DVT while she was pregnant? That increases her risk even more. Is it a significant, therefore, family history? That is what I'm trying to get. Are there more family members who have got a VTE? And I will ask the patient, has she ever been on the pill? So if a patient comes to me and tells me my mother had a DVT when she was pregnant, but the patient herself is in her first pregnancy, she's never been pregnant before, and she was on the pill for 10 years, I'd be quite reassured because she has been estrogen challenged for 10 years without having had a DVT. But I would still do a thrombophilia screen. So if a woman has had a significant family history of a VTE, especially if the VTE was unprovoked or estrogen related, they do get a heritable thrombophilia screen. Now, heritable thrombophilia screen is pretty much this. Okay, so these are blood conditions which you inherit and which increase your risk of getting a DVT. 2 of them are mutations of the coagulation system, while 3 of them are deficiencies of your natural anticoagulants. So the mutations are factor V Leiden, which is the commonest. It occurs in 5% of the Northern European population, and it doubles your risk of VTE. Prothrombin gene mutation is quite similar. These 3 are relatively rare, and nature is quite kind to us because these ones are very rare, but they are very prothrombotic. So if you have antithrombin deficiency, your risk of clotting in pregnancy is 1 in 2. So extremely high. In fact, these women are usually on long-term warfarin. So this is a test which we do in women who have a family history of VTE. So if they have antithrombin deficiency, for example, they get antenatal and postnatal low molecular weight heparin with high doses of this throughout their pregnancy. If they have protein C, protein S, or homozygous factor V Leiden, which means they got the mutation from both of their parents, they will require antenatal and postnatal heparin. If they have heterozygous factor V Leiden or prothrombin gene mutation, which are the least prothrombotic of them all, they only get it postnatally, which is when the risk is highest, for 6 weeks. Now, one of the new things which has been inserted in the new guideline is essentially every woman who is pregnant and is in hospital for whatever reason, except for labor, she will require low molecular weight heparin straight away. Okay? Because if you're an inpatient and you're pregnant, your risk of getting a VTE is 18 times higher. So it's pretty high. Whatever the reason of your admission, whether it's hyperemesis, whether it's reduced fetal movements, whether it's preeclampsia, 18 times higher. And that risk remains 6-fold high up to 28 days post-discharge. This is from very, very strong, robust demographic studies. So essentially, especially if you're in the 3rd trimester or even more than 35 years old. So every woman who is pregnant and is in hospital, irrespective of any other risk factors, has to get tinzaparin or whatever low molecular weight heparin the hospital uses. Antenatal prophylaxis, you need to start, as I said, from the word go, because that is when the coagulation changes occur. If you have 3 risk factors, you start from 28 weeks. If you're on antenatal prophylaxis, you will require it for 6 weeks postnatally. We tell them to inject in the morning. Anybody has any clues why? Not in the evening? What's the difference? As an obstetrician, I know all too well, unfortunately, that most labor happens at night. So if a woman labors in the evening at 6 p.m., if she has her injection in the evening and she labors at night, she can't have an epidural until 12 hours have passed from her last injection. While if she has her injection in the morning and she labors at night, it's more than 12 hours from her last injection. That's just a practical thing, really. And if they are being induced, then if their labor is being started off, therefore pharmacologically, then we stop the injection the day before. So 12 hours will have to pass from the last injection before they can have an epidural. And you have to restart it 4 to 6 hours after delivery, or after the epidural has been removed. Because then that is when they are at their highest risk, immediately postnatally. Yeah? But you have to balance that against the risk of bleeding as well, because they are also at a high risk of bleeding postnatally. So as soon as midwives are very good at assessing the amount of bleeding postnatally. If the bleeding is settling within 4 to 6 hours, you start the low molecular weight heparin once again. Okay, so now I've got a few cases which will help us sort of understand what we do with regards to prevent VTE in pregnancy, bringing together all lifestyle. And I'd like you to participate as much as possible. Don't worry if you get it wrong, okay? We're just here to learn. So, and these are cases which we see on a weekly basis in our clinic. So a 24-year-old woman who's 8 weeks pregnant. She had a pulmonary embolism while she was on the oral contraceptive pill 6 years ago. And it was a proper PE, which required anticoagulation for 6 months. There's no family history of VTE. And now she's pregnant. So does she need low molecular weight heparin? Yes. From when? Now. From now. Very good. Oh, great. You can come and do my clinic. Okay. Would your recommendation change if she has a thrombophilia? So let's say I do a thrombophilia screen on her, even though there's no real need, because she's actually the history is quite valid. But let's say we do a thrombophilia screen. Is it necessary to do a thrombophilia screen? It's not. But let's say she has a thrombophilia. Would that change your management? So it depends on what thrombophilia she has. Yeah, so if it's the milder thrombophils like factor V Leiden, it won't change your management. But if she has one of the more severe thrombophils like antithrombin deficiency, she will require higher dosage of prophylaxis with close monitoring. So that's correct. They get slightly harder now, okay, as we go on. So 27-year-old in her first pregnancy, she's 12 weeks pregnant. She's found to have prothrombin gene mutation, another thrombophilia. During the routine tests following a pill scare, this happened quite a few years ago now, when they found that there was a link between the oral contraceptive pill and VTE. So many women were having thrombophilia screens left, right, and center. So this woman was found to have a prothrombin gene mutation. But she had been on the pill uneventfully for 2 years. And there's no relevant family history. So my question is, does she require low molecular weight heparin antenatally? How many say no? How many say yes? Okay, the answer is no, correct. Okay, so she doesn't need thromboprophylaxis antenatally, but she needs it postnatally. Yeah, she needs it postnatally because the risk is higher postnatally. And what we do in these cases, we recommend 10 days of low molecular weight heparin after a normal delivery. But 6 weeks after a C-section. Because when you compare a C-section to a normal delivery, as I said, the risk is 5 times higher of getting a VTE. So if you have a thrombophilia with no relevant VTE history, they just get postnatal thromboprophylaxis, assuming there's no other risk factors. Now, this woman is in her second pregnancy. She's 37 weeks. She developed the left popliteal DVT, so quite unusual, below knee DVT. But that's what she got at 12 weeks. And she's been on therapeutic low molecular weight heparin. Now, therapeutic low molecular weight heparin, which you give to treat VTE, not to prevent VTE, is a bit of a problem in labor because they are likely to bleed, especially if they've just had their low molecular weight heparin. And 24 hours will have to pass from the last injection before they can have an epidural, not 12. So, now that she's 37 weeks, would you do anything different? Probably the answer is yes, otherwise I wouldn't have asked you. But what would you do? What would you do different?
Would you be ultrasound to see if the previous DVT has gone at 25 weeks of treatment dose?
So it probably would have gone, but it's difficult to say because the scan is not very accurate in distinguishing fresh clot from fibrosis, you see, from organized clot. Excellent, very good. You can definitely come and do my clinic. So I would convert her, because it was a low grade VTE, it was below the knee, yeah? I would convert her to a prophylactic dose at this stage of pregnancy. That will make labor much easier. Yeah? So that is what I would do. Now, this woman is in her first pregnancy. She had a left femoral DVT, so a high-grade DVT above the knee at 32 weeks. She's on therapeutic low molecular weight heparin, and she's being induced for diabetes. We tend to induce diabetic women before 40 weeks. So what would her intrapartum anticoagulation plan be? So when will she have her last injection? Let's say she's being induced on the Monday. When will her last tinzaparin injection be? the day before, yeah, on the Sunday, yeah. And then what we do is, so it's a bit of a balance postnatally between trying to prevent a VTE, which is at her highest risk, versus bleeding, which can be quite scary and quite dangerous as well. So she doesn't go back to a therapeutic dose straight away after delivery. We start her off on a prophylactic dose for the first 24 to 48 hours, and then gradually build up her therapeutic dose back to what it was prior to delivery. Yeah? And she needs to be on therapeutic tinzaparin and on molecular weight heparin for 6 months in total. Now, this is slightly different because she developed a DVT at 36 weeks. So, how would your management differ compared to the previous one, you think? We're quite late on. She might go into labor, and it's a proper DVT. It's a left iliofemoral, so it's in the pelvis. It's partially in the pelvis. What am I worried of here? A pulmonary embolism. So studies have shown that the risk of pulmonary embolism is significant, especially during labor when she is pushing, if she hasn't had at least 6 weeks of anticoagulation. So she wouldn't have had 6 weeks of anticoagulation by the time she's going to go into labor, because she's 36 weeks already. So these are the only situations where you would consider a filter in the inferior vena cava. It's like an umbrella, which is the other way around. So it's like a proper umbrella, not the other way around, an umbrella in the inferior vena cava, which blocks potential blood clots from going into the pulmonary circulation. Yeah? But they're not easy. They're very difficult to put in. The radiologists do them, and they're even harder to get out. Yeah? And if you don't manage to get them out, they might need long-term anticoagulation, so warfarin for the rest of their life. So it can be quite tricky. But you would consider it if you had a fresh, large DVT after 34 weeks. Okay, so in conclusion, therefore, as I said, pregnancy increases your risk of VTE by at least 5 times, with an absolute risk of 1 in 1,000. There are many risk factors which increase your risk further. The highest risk is having had a VTE in the past, which increases your risk to 1 in 10. Heparin, as I said, is safe and effective in reducing the risk of VTE by about 90%. But we need to be very, very careful to make sure we prevent our VTEs as much as we can, because it is still, unfortunately, the major cause of death in pregnancy in the UK. I'm happy to take questions if you have any.
So Etienne, again, another great lecture, and certainly I've learned a lot. I've also learned that it's really safer to be a man. But seriously, excellent lecture. Questions for Etienne on that? Kathryn at the back?
Thank you very much, Etienne. Just on your last patient's case that you talked about, how would you, if you put an IVC filter in, how would you then manage? Would you still induce labour so that you can plan the dosing? And would you ever use unfractionated heparin?
So we don't like using UFH very much because we're not very used to it. So the last case we had, I probably shouldn't say this, but anyway, but the last case we had, who was on UFH, they forgot to switch the UFH off while she was labouring. So they only realized that she was on a fractionated heparin while she was pushing. And she was a lady who was a para 3. So she was about to have a baby with the highest dose of anticoagulation you can think of during the biggest hemostatic challenge she's ever going to have. So we had to use protamine in that case. So I don't like using UFH for that reason. So you would still anticoagulate her, obviously, notwithstanding having the filter, and you would organize an induction, yes. I always induce women who are on therapeutic TINs to be able to manage the low molecular weight heparin. But you want to induce them when their body is ready to have a baby, because the last thing you want to do is have them in hospital for 3 days waiting for the induction process to work when they are off heparin then, and obviously increase the risk of getting a VTE. So we start examining them vaginally from about 38 weeks, and when the cervix has begun to open up, then organize an induction.
Gentleman at the back.
Sorry, 2 questions. So the first one, you don't mention mechanical prophylaxis much, but is it something that you...
So TED stockings in pregnancy are a waste of time. So they do not reduce your risk of VTE at all. There is studies outside of pregnancy, obviously, which has shown that stockings does reduce VTE risk, but not in pregnancy, because blood in pregnancy is completely different compared to when you're not pregnant. So we only use TED stockings in women, because most of our women are on heparin anyway. So if you're on a strong anticoagulant, a pair of tights is not going to add anything more to your low molecular weight heparin. But if you're not on a heparin, like women who have had an elective section, for example, elective C-section, those women are not on heparin. Those are given stockings. I'm not saying, obviously, the Flowtron, that's different. Yeah, so we do use floaterons in women who cannot have heparin but need it because they are bleeding, for example. So we do use floaterons, but not stocking.
Okay, and my second question, in the postnatal phase, you seem to have two pathways, one for 10 days for someone that's got that's done a normal vaginal delivery, and the 6 weeks for the caesarean. But you mentioned that the emergency caesarean versus a planned caesarean were actually different risk factors. Is there not a middle pathway, or is it just 10 days of therapy or 6 weeks of therapy?
I mean, the challenge we have is because every case is so different, it's impossible to have a guideline which covers every single case. So you have a guideline, but that's always open to interpretation. You can't cover every single case on a guideline. So if you have an elective section and no other risk factors, you don't get any prophylaxis at all. If you have an emergency section, you get 10 days. But if you have additional risk factors, like you had a massive hemorrhage, for example, and you have a high BMI, then you should consider 6 weeks. Yeah, so that's where the difference lies.
My question is about, you mentioned about the thrombophilia screen and about some thrombophilic factors, but what about lupus anticoagulant? And what would you comment on the protein C and S levels during pregnancy? And the third thing, the last question is, once you've started low molecular weight heparin, how do you monitor the blood counts of the patients?
So lupus anticoagulant, unfortunately, you get false positives in pregnancy. So you can't really rely on it. We do sometimes do it if you have a strong suspicion of antiphospholipid syndrome, like recurrent miscarriages or preeclampsia. But you have to interpret it with caution, because you can get false positives. With regards to the heritable thrombophilias, so there's 5 of them, as I've mentioned. The mutations, there's a strong misconception that you can't do a thrombophilia screen in pregnancy, which is wrong. So the 2 mutations are mutations, so it doesn't matter whether you're pregnant or not. You can test for it in pregnancy. Antithrombin levels do not change in pregnancy. They drop postnatally, so you can test. Protein C becomes less active in pregnancy, but the levels remain the same, so you can check protein C levels in pregnancy. Protein S drops, so you can't test for protein S. So what I do is on order comes, I tick those 4, and I don't tick protein S, because you can't interpret it. Oh, and yes, so we do anti-10A monitoring for our ladies who are high risk, and we aim for ranges between 0.2 and 0.4.
I was just wondering, in terms of dosing postnatally, so if somebody in terms of weight is very different and they need treatment dose afterwards, would we adjust after?
Yeah, so our guidelines say that you need to have the weight at the time. So the woman has to be weighed before starting low molecular weight heparin, which is not a problem if they've had a normal delivery, but it's a challenge if they've had a C-section. You can't really weigh them after a major operation. So we then go for the latest weight prior to delivery. They have to be weighed when they're in hospital. And then you calculate, you remove the weight of the baby, of the placenta and the liquor. So, yeah.
Thank you.
So it would be remiss of me not to thank Louise for putting this all together. I think it was a really excellent and interesting programme. So again, thank you, Louise. From Leo Farmer again. It's always nice to have a good lunch, and Leo Farmer obviously are pushing the educational component of this quite rightly, very firmly. So thank you all for coming, and thank you again, Louise. Thank you.